evening, friends and colleagues. This is Best of ASH, which has been going on from 24th of January. I will continue till Sunday. Today is day 4. This webinar is brought to you courtesy Mumbai Hematology Group, managed by Mice Ideas. We have 2 lectures today. The first one on multiple myeloma by none other than Dr. Vincent Rajkumar, who is consultant, Division of Hematology, Department of Internal Medicine at the prestigious Mayo Clinic, Rochester, Minnesota, US. This part of the webinar today is supported by Alkem. This will be followed by the second lecture on role of radiation in hematological malignancies, key knowledge for the medical oncologists. This will be by Dr. Dabaja, who is Professor and Section Chief of Hematology, the Department of Radiation Oncology at University of Texas, MD Anderson Cancer Center, Director of Research, International Lymphoma Radiation Oncology Group, Houston, Texas. And this part of the webinar is supported by Natco Oncology. I thank Mr. Abhijit Nazare and the team from Alkem, James Rajakumar and the team from Natco, Mr. Rajesh, Mr. Kalpesh and the team from Mice Ideas, the Executive Committee of Mumbai Hematology Group, our guest speakers, Dr. Vincent Rajkumar from Mayo Clinic and Dr. Bouthaina Dabaja from MD Anderson. All our discussants who are themselves eminent hematologists, hemato-oncologists or radiotherapists. New participants for sparing your Thursday evening. Our discussants today are once again galaxy of stars from India. We have Dr. Nagaraj Hulgol, who is Chief Radiation Oncologist from Department of Radiation Oncology, Nanavati Super Specialty Hospital, Vile Parle, Mumbai. Dr. Bhavsai Bagal, Professor and Consultant Medical Oncologist from Tata Memorial Center, Parel, Mumbai. Dr. Priyanka Srivastava, she is Consultant Medical Oncologist, Associate Professor of Medicine, Pramukh Swami Medical College, Karamsad, Anand. Dr. Shailendra Prasad Verma, Associate Professor, Department of Clinical Hematology, King George Medical University, Lucknow. Dr. Shinto Francis Tekunan, who is Senior Consultant and Chief, Department of Clinical Hematology and Hemato-Oncology at Baby Memorial Hospital, Kozhikode. Dr. Tufan Dolai, Professor and Head, Department of Hematology at NRS Medical College Hospital, Calcutta. Dr. Anand Gokad, Associate Professor, Department of Medical Oncology, Tata Memorial Center, Mumbai. Dr. Afaq Ahmad Khan, Assistant Professor, Consultant in Clinical Hematology, Hemato-Oncology and Transplant Physician, Department of Clinical Hematology at Sher-e-Kashmir Institute of Medical Sciences, Srinagar, J&K. Dr. Aditi Tanki, Consultant Medical and Hemato-Oncologist at Sterling Cancer Hospital, Rajkot. Dr. Jeevan Kumar Garg, Senior Consultant, Department of Hematology and Transplant, Tata Medical Center, Kolkata. Dr. J.M. Khunga, Consultant Professor and HOD, Department of Hematology, Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi, former Secretary, Delhi Society of Hematology, former Vice President, ISHBT, 2016-17. Now it's my extreme delight and pleasure to introduce our chief guest of the day. I'm grateful to Brigadier Dr. Paramjit S Dhot, VSM, for sparing his valuable time sitting in Toronto, but being with us to bless us with his inaugural speech. Everyone knows him in the field of hematology from India and probably all over the globe, but I complete my formalities. His MD, Postdoc Fellow Hematology, AIMS Delhi, FI SHTM, President Society of Cellular Therapy, Past President, Indian Society of Hematology and Transfusion Medicine, Past President, Delhi Society of Hematology, Member Governing Council, National AIDS Control Organization, Ministry of Health and Family Welfare, Member Committee for Stem Cell Therapy, DCGI, Ministry of Health, Member National Blood Transfusion Council, member Stem Cell Research Committee, MIT University, Noida, member editorial board, Asian Journal of Transfusion Medicine, member editorial board, Indian Journal of Hematology and Blood Transfusion. Well, I can go on and on and on, but I have to stop somewhere and permit him to inaugurate this webinar and give the inaugural speech. Over to you, sir, Dr. Dhot. We can't hear you. You are muted.
Good evening, ladies and gentlemen. Thank you very much, Dr. Agarwal. You are the top global hematologist and a medical educator. I've attended hematology updates for 2 decades and I'm again here. Thank you very much. It's an honor and privilege for me to be the chief guest to inaugurate today's program. And I thank you for inviting me to be the chief guest for the best of ASH on the 3rd day. We have had a galaxy of speakers, and today we have 2 more experts, that is Dr. Vincent and Dr. And once again, I thank you. I thank you from the bottom of my heart for having me here. Thank you so very much. You educate all of us with correct knowledge. Thank you very much. All the best. Enjoy the program. Thank you, Dr. Agarwal. Thank you very much.
Thank you, Dr. Paramjit Dhot. That was a very brief speech, but thank you very much for being with us despite being in Toronto. And you showed us the snow around. Why don't you show it to our other faculty also?
Excellent, excellent, excellent. Yeah.
Please do so.
You want to see the snow in Toronto?
Yes, we want to see that. Minus 28 degrees.
Okay. Okay, okay. Just a moment. See the snow here and the snow. The Ontario lake is completely frozen. Thank you. Thank you very much. Thanks a lot. Thank you.
Okay. I'm extremely grateful to you for being with us, for inaugurating this webinar.
Thank you. Thank you. Thank you.
Couple of minutes, we will begin with the first lecture. We'll have a break for about 2 minutes, and then we begin with the scientific session.
Okay.
Already introduced you, but I'll just reintroduce you briefly. So
no need. I'm ready to start.
Everybody knows you. Just Dr. Vincent has joined now. So as you know, he has been our teacher, philosopher, educator, and all the help in the field of myeloma in uplifting the care of this disease in this country and all over the globe. His contribution to the field of myeloma has been immense. For the formalities, he's from Department of Internal Medicine, Mayo Clinic, Rochester, Minnesota, and tremendous contribution to myeloma, and still active and going on strongly. So I don't want to stand between you and him. I request him to give his talk.
Thank you so much for having me. Am I very clear now when I speak?
Absolutely.
Okay, great. Hi, everyone. I'm just very delighted. I have done these meetings before face to face. Too bad that we have to do it virtually. I look forward to presenting pretty much a comprehensive 2022 myeloma update, and then also highlight some of the important findings that came at ASH. And then we'll have time for questions, any questions that you have. I will share my screen. I'm sorry, I have to do some. I may have to rejoin.
Sure.
Let me see if I can share my screen this time, because my settings.
Yes.
Didn't. Great. There we are. I have no conflicts to disclose. So starting off, I'll cover myeloma, a little bit of smoldering multiple myeloma, and also relapsed, and also MGUS, what advances have happened. But start off with myeloma. I think the main thing to keep in mind is what we call myeloma is a collection of probably different diseases. We have several subtypes, and each subtype can sometimes behave very differently than the other. And I think you can group them broadly into those which are high risk. That's about 25% of myeloma, and those that are standard risk, which will be about 75% of myeloma. Now, of the high risk, there's the classic 414, 1416, 1420, and also deletion 17p. Now, 1q gain is a little complicated. If you have 3 copies of 1q, that increases the risk, but 4 or more copies, which is called 1q amp, that increases the risk further. When you have 2 high-risk features, then we call it double hit myeloma, because in various combinations, you can see that having more than 1 high-risk abnormality increases the risk further, and then 3 or more increases the risk even more. On the other hand, patients who have trisomies alone, or patients who have 1114 or 614 translocation generally are considered standard risk, and the survival is quite different between these 2 groups even today. When we start thinking about initial therapy of multiple myeloma, the first thing is like, what do we use for initial therapy? And for a number of years now, we have been using in the US and I think in India as well, VRD. VRD is bortezomib lendex, and it's really based on the SWOG trial showing that bortezomib lendex is better than lendex. Now note that the bortezomib in the SWOG trial was given twice a week, whereas more commonly nowadays, we are giving it once a week subcutaneously. The SWOG trial showed that progression-free survival is significantly longer with the triplet. And I think that's really important here because it's almost 4 years with just the triplet. This was a trial even without transplant. And I know bortezomib Lendex is an affordable regimen in India. And so I think this would be a really good initial therapy regimen. And who knows in 4 years what the cost might be of some of these new treatments coming. And at that time, you can always use those drugs and you would have delivered really cost-effective care. Overall survival with this regimen was about 6 years. And again, this is without transplant. Some of these patients got transplanted delayed, but it was a trial that was done started in 2007. So some of these numbers don't even reflect what's going on today. Survival in myeloma has improved even more than this trial. Now, one of the competitions for VRD for initial therapy, daratumumab Lendex. And Dara Lendex is a regimen that you will hear more about. I think Dr. Mateos is speaking on daratumumab-based regimens for frontline therapy and relapse later on in this meeting. Dara Lendex is a great regimen. The update of the Maya trial shows significant improvement in progression-free and in overall survival. You have progression-free survival that's going 5-6 years. And so it is a very good alternative to VRD. The problem with Dara Lendex, and this is something I think all of you know better than me, is Dara is more expensive than bortezomib, even in India, because it's a biological. And so when you use Dara for frontline, you are taking on the extra cost right now, as opposed to who knows what the price might be 4 years from now if you had started with VRD. The other problem with Dara is that this survival curve and all of the information that you hear about this trial is using Dara every month for 3-4 years, 5 years until progression, which is a triplet until progression. Whereas with VRD, we usually use the VRD only for about 6 to 9 months. And after that, we are only talking about lenalidomide maintenance to see the results I showed you earlier. So really the cost and toxicity differences come from both the fact you have to give the triplet for a long time here and the fact that it's going to be a long drawn out cost process for toxicity process as well. Also, in terms of COVID, we have heard that Dara is very effective in suppressing antibody responses that you get from either the natural infection or with COVID vaccines, so that patients may be more susceptible. So keep that also in mind. I like Dara frontline. We are doing a trial with Dara frontline right now in ECOG, but I think you need to know the caveat so you can select the regimens and compare the two carefully. You can also consider, I mean, many people have looked at carfilzomib instead of bortezomib. And here the idea is carfilzomib is a more powerful, more potent inhibitor of the proteasome complex than bortezomib, and maybe that'll be better. But you can see in this trial that was done by Dr. Shaji Kumar, who's familiar to all of you. Shaji did this trial in over 1,000 patients. And he found no difference in either progression-free survival or overall survival when you compare to VRD. But there is slightly higher risk of cardiotoxicity and renal toxicity with carfilzomib and higher risk of neurotoxicity with bortezomib. The neurotoxicity with bortezomib you can manage by using once a week sub-Q. Now, keep in mind, this trial was done only in standard risk. And so some people say, well, this is only in standard risk. But my point is that if you're not able to show a significant benefit after looking at over 1,000 standard risk patients, the idea that carfilzomib will somehow miraculously be better than bortezomib in high risk patients is a little hard to believe. So I think that the onus of proof is now on carfilzomib to show that it's indeed better than bortezomib in the frontline setting. We don't use it now as much because we use either bortezomib Lendex or Dara Lendex or the quadruplet, as I will show you. What about quadruplets? Here you're adding to a triplet, so you're building on the triplet rather than replacing bortezomib with Dara. And I think this is probably the way of the future. The only barrier would be cost, and the other barrier would be what happens to the extra toxicity that you get with a 4-drug regimen. In the Cassiopeia trial, they didn't use lenalidomide, but they used thalidomide. So it's a good, reasonable surrogate to look at. And you can see here, when you use the 4-drug regimen, you do get a better PFS and better overall survival even. However, we don't know if this plays out if you use lenalidomide, and the phase 3 trials with VRD versus DARA-VRD are awaited. We do have phase 2 data from DARA-VRD. This is a randomized phase 2 trial, the Griffin trial. You can see the publication in Blood that came last year, which shows that if you use DARA-VRD, you get a higher stringent CR rate than with VRD. And you also get a higher MRD negative rate, like 50% versus 20% by using the 4-drug combo. At the time of this paper, the PFS differences were not yet significant. They had an update this year at ASH, and that is shown here. You can see here that the PFS is almost significant. It's a 50% reduction in the risk of progression when you use a 4-drug combo. At 3 years, the PFS difference is 89% versus 80%, looking very promising for the DARA-VRD group. I mean, if you have almost 90% of people progression-free in newly diagnosed disease with a 4-drug regimen, that is something to keep in mind. You know, it's an important finding. And I think we'll wait and see what Perseus and other trials show. There are also trials with isatuximab, which is a same CD38 monoclonal antibody made by Sanofi, to see if that has the same result. But it is promising, and this is something we need to keep in mind. Overall survival differences haven't emerged yet, but it is too early in the Maya trial. Overall survival is several years, and so if at all there is differences, it'll take 8-9 years to develop, and so we are too early to make any conclusion on that. So that's in initial therapy. So we're really talking about like DARA-VRD, DARA or VRD or DARA-RD as the 3 main options that will cover almost 90% of myeloma patients that we currently treat or more. Once you're done with the induction or the initial therapy for transplant eligible patients, we are considering transplant. Transplant is still an important treatment option. The real question right now is not so much whether transplant is useful, but when to do the transplant. Is it early, better, or delayed? And there's some good important results to keep in mind. This actually came last ASH, and this is the IFM trial, IFM trial of early versus delayed transplant. So the delayed transplant group got just VRD. The transplant group got VRD plus transplant followed by maintenance. You can see here that the progression-free survival is indeed longer with a transplant. However, overall survival at 8 years is identical. That means whether you do the transplant early or delayed doesn't make much of a difference. Now, some of my transplant colleagues sometimes say, well, if you do it delayed, not everybody gets a transplant. But that's really amazing, because even though everybody did not get a transplant at delayed, the overall survival is still identical at 8 years. That means transplant, this almost auto-selects who would benefit the most from transplant. And so I look at this data, and I don't insist to my patients that everyone has to get a transplant early on. I look at what they want in life and then make that decision. You also have to look at what situation it is, what the costs are, where are we going to do the transplant, and what are the results of that institution when making that decision. Also, delayed transplant is not that easy. You have to have the facility to harvest and cryopreserve stem cells. If you don't have that, then this trial doesn't apply either. So there's a lot of factors to consider. Another important factor is the risk status. If the patient is high risk, I prefer early transplant. If the patient is standard risk, I give them the choice between early and delayed. If you have if you have a patient who is close to 65 or 70, then doing a delayed may not be that easy. But the younger the patient, the delayed becomes an option. Once we are done with the transplant, we are all doing LEN maintenance, and that's based on this meta-analysis. You have a significant improvement in both PFS and overall survival. So that's something that certainly is still remaining the standard of care. Now, one of the ways to improve on LEN maintenance is to see if we can add DARA. This Cassiopeia trial did not add DARA. They just used DARA alone for maintenance. And there's some really important data here. This was presented at ASH and ASCO, and it's been published this year in the Lancet Oncology. But what I want you to keep in mind is this. The trial looked at DARA VTD versus VTD, and then patients were randomized after transplant to DARA versus observation. So you really have 4 groups of patients: those who got VTD and then nothing, those who got VTD and then DARA, those who got DARA VTD and then nothing, or DARA VTD and DARA. You can see here that if you got VTD and then no maintenance, that group didn't do as well. But all the other 3 groups did the same, which means that if you gave DARA as induction, as part of a 4-drug combination for just 4 or 6 months, you get almost all the benefits, so that giving DARA for 3-4 years as maintenance doesn't seem to add as much. And this is really important for India. Let's say if you think you want to do a 4-drug induction, you do the 4-drug induction transplant, and then you can just do LEN maintenance. You get all of the benefit with that. You don't need to give the DARA on top of the LEN to increase the cost and toxicity. So here's my algorithm now for newly diagnosed myeloma. This is transplant eligible for standard risk patients, VRD 3-4 cycles, early transplant, LEN maintenance. That's a good option. If the patient is younger and willing to, and you can collect stem cells for future and really wants to delay the transplant, you give about 5 to 8 cycles or so of VRD, and then LEN maintenance, and then do the transplant at delayed. For high-risk patients, you can either use VRD, or for many high-risk patients who can afford it, DARA VRD is also reasonable, 3 to 4 cycles, followed by early transplant. And then for high-risk patients, we use maintenance with both bortezomib and lenalidomide. In the maintenance setting, we use bortezomib once every 2 weeks. For transplant ineligible patients, very similar algorithm. For standard risk patients, you can either do VRD or DARA-RD. With DARA-RD, you're going to give DARA until progression. With VRD, you give VRD for about 6 months, and then you do LEN maintenance. High-risk patients, we usually use VRD, and then bortezomib plus LEN. For high-risk patients, you can use DARA, but then you'll be changing the maintenance. So that's why I usually prefer stick to the same regimen. And this whole topic is covered in the current treatment algorithms in Blood Cancer Journal that Shaji and I published last year, or actually 2020. And this year I will be publishing very soon the 2022 update in the American Journal of Hematology. Let's switch on to relapse multiple myeloma. This is a very difficult field because we have a number of drugs. So it's not really easy to give a prescription in terms of what would you do, because it really depends on a number of factors. Easily summarized by the acronym TRAP, T-R-A-P, timing of the relapse. When is the relapse? Is it early, late? How did they respond to the previous therapy? How aggressive is the relapse? Is it just a paraprotein increase, or is it lytic lesions or plasmacytomas? And then what is the performance status of the patient? And finally, in many countries, what are the treatments that are really available for treatment? For first relapse, there have been a number of triplets that have been studied. They have been compared to a doublet, either to Lendex or bortezomib dex, and you have a whole list of them. Ixazomib Lendex, Elo Lendex, carfilzomib Lendex, Dara Lendex. DARA, bortezomib dex. Panabinostat has been withdrawn from the US market, so I'm leaving that out. You can see here they all do well. The triplets do well. So basically, we prefer a triplet for first relapse. But because there is no randomized trial comparing one triplet versus the other, it's hard to know which one's the best option. In general, if you had everything equal, then DARA-based regimens seem to give you the best reduction in hazard ratio. So I prefer DARA-based regimen for the first relapse. However, if the patient's already had DARA for a while, let's say DARA RD, then you may have to use a different regimen. Now, many of these trials which I just listed were done in Europe in a period of time when lenalidomide was not used as frontline. But India is one of the countries besides the US which has used lenalidomide for frontline for a number of years. So a number of our patients have already progressed on lenalidomide, already refractory to len, already exposed to len. So none of those trials actually apply to our patients. And so we have to look at some newer trials. And I list about 5 trials which have used, which have looked at patients who already had lenalidomide and which have looked at other combinations. So here's the Candor trial, which used DARA, carfilzomib dex. And I think carfilzomib is a good regimen for first relapse. You can see here DARA, carfilzomib dex superior to carfilzomib dex in PFS. And there is another CD38 monoclonal antibody, isatuximab, and they've done a trial as well with isatuximab, carfilzomib dex that also is better. So a CD38 antibody with carfilzomib is a good choice for first relapse. Similarly, pomalidomide. Pomalidomide can work in patients who have failed lenalidomide, and you can see here DARA PomDex in the Apollo trial, and you can use isatuximab instead of DARA. In the Acaria trial, they found a similar benefit. So a CD38 antibody with pomalidomide also is a good option for first relapse. Now, another regimen that's fairly inexpensive, don't need a monoclonal antibody, and can work in patients who are progressing on len maintenance is pomalidomide, bortezomib dex, as shown in the Optimism trial, significant improvement in PFS, works in lenalidomide refractory patients. So this would be a good option to keep in mind, cost-effective one. So here's my algorithm for first relapse. It really depends on whether the patient is relapsing on lenalidomide or not. If the patient is relapsing on lenalidomide, we have to use something other than lenalidomide. If the patient is not refractory to lenalidomide, then you can use DARA-RD based on the Pollux trial. If the patient is refractory to DARA, then carfilzomib RD based on the Aspire trial would be a good option. For frail patients, elotuzumab RD or ixazomib RD can be used. And here, if patients are refractory to lenalidomide, as I mentioned here, you can use a carfilzomib-based regimen with a monoclonal antibody such as DARA-KD or ISA-KD, or a pomalidomide-based regimen such as DARA-PD or ISA-PD. If patients are DARA refractory, then you have to use other regimens that don't contain DARA, like KPD. Now, when you come to second or higher relapses, the math becomes even more complicated because patients have received a number of different drugs already, and you really have to look at what the treatment that they've had before, what are they sensitive to still, and I use a triplet using 2 new drugs that the patient has not previously been refractory to as a principle. So you can use any of the first relapse options that have not been tried, which meet this principle. You can also have additional options, and this is going to be the era of immunotherapy. We have CAR-T. One of them is approved in the US, Ida-cel. We think Cilta-cel made by Janssen will get approved this year. Those would be a good, really good initial treatment option. KCD, VCD, IXA-CD basically tell you that don't forget alkylators. Alkylator-based regimens can be really valuable. I found KCD and DARA-KCD particularly useful. ELO-containing regimen, belantamab has been somewhat of a disappointment at Mayo. We are getting only a PFS of 2 months with this regimen. There are occasional patients who do well, but with the risk of keratopathy, at least for us, given CAR-T coming in, the use is lesser now. And I think with bispecifics, it might get even more down the road. Anthracycline-containing regimens, VDT pays, good old regimen. It's still useful in patients who have aggressive disease, but you use it only for 1 or 2 cycles, and then you have to switch to some other milder regimen. Selinexor, venetoclax. Venetoclax is useful only in the 11-14 group. I still use intravenous melphalan, probably at a dose of 16 to 25 milligrams per meter squared. If you use the higher dose, 25 per meter squared, you need growth factor support, and really it's like a mini high dose therapy. Bendamustine-based regimens, quadruplet regimens, and so on. I will highlight some of the new treatments that we heard about at ASH this year, which are really promising. Cilta-cel CAR-T against BCMA. Dr. Tom Martin presented these data, really impressive because high response rates, 80-90% response rates. And the PFS at 2 years is 70%. The grade 3-4 neurotoxicity, cytokine release syndrome are all low in the 5% range. The only problem is very expensive. I don't know when it will be available in other countries. Hopefully this is more a proof of principles, and homegrown CAR-T cells in India might be a more cost-effective option down the road in the future, I hope. Overall survival with Cilta-cel, 74% at 2 years, great results. We are really, again, hoping that this gets approved sometime this year. Now, a lot of promise for bispecifics, because we know with CAR-T, you have to collect the cells, you have to send it for processing. There's only limited options. With ide-cel, for example, there's only 1 or 2 patients per month that Mayo Clinic can treat. So it's limits the amount of people you can help. So bispecifics, which are off the shelf, can do something like the same thing. And the bispecifics are monoclonal antibodies where one end binds to CD3, to the T cell, and the other binds to the plasma cells. They have 2 epitopes that I target, and they bring the T cell close to the plasma cell and do something like what the CAR-T would do. And the antibody you target on the plasma cell will determine the specificity of this bispecific. And a lot of the bispecifics target BCMA, B cell maturation antigen, which is the same antigen that CAR-Ts like ide-cel and Cilta-cel target. So if somebody's already failed CAR-Ts which target BCMA, I don't know how the bispecifics targeting BCMA would work. Time will tell. But this is how they work. And at ASH this year, we heard about a number of bispecifics. You can see here, many of them are targeting BCMA. I hope all of them are approved because then they will compete, and hopefully that means the prices will be lower and more affordable. I'm also happy that there are bispecifics that target an antigen on the plasma cell that is not BCMA, because once patients have failed BCMA therapies, you're looking at other antigens. And so talquetamab targeting GPRC5D and cevostamab targeting FcRH5, these are highly expressed on plasma cells, are all promising. Look at the response rates. These are 50, 60% or higher. And this is really impressive because these are single agent response rate with these bispecifics. And if you compare to DARA single agent, DARA was only 30% single agent response rate. Bortezomib, lenalidomide, pomalidomide, carfilzomib, they all had only about a 30% single agent response rate. So if the bispecifics truly have a 60% response rate and they are tolerable and they don't cause too much side effects, it's a really good day for myeloma. So time will tell because these are all phase 2s, but I'm hoping at least one of them, probably teclistamab, gets approved in the US this year. Here is the data with teclistamab presented at ASH. Philippe Moreau presented this. You can see here a CR rate of almost 30%, an overall response rate of 62%, MRD negative rate of 25% in patients with multiply refractory multiple myeloma. So this is really promising. Here is data with talquetamab. This is targeting something other than BCMA from the Monumental trial. This is showing again a 60-70% overall response rate and a high CR rate as well. Very quick action. Again, only time will tell how these play out and how these play out in BCMA exposed patients, but it's very promising nonetheless. A lot of these bispecifics also have CAR-T-like side effect with cytokine release syndrome, and we have to just be careful. There's other toxicities, including skin toxicity, we have to keep in mind. Sabostimab targets another antigen called FcRH5 on the plasma cell. Again, response rates of almost 60%. Hopefully, again, approved in the next year or two. Promising bispecific. This is a summary slide showing all of the drugs that are active in myeloma. Two of them I had to remove. That's what happened in the last year. One was melflufen, withdrawn from the market. The other is panobinostat, withdrawn from the market. But these are the remaining ones. We have the approved ones. I think I have shown them in the black font. All of the unapproved ones are in the blue font, and you can see there's a lot of them coming out. These all have shown single agent activity, almost all of them, elotuzumab and selinexor less so. With all these drugs, it becomes very hard to give a recipe in terms of this is what you should use at second line, third line, fourth line. I think it's important to keep the principles in mind that you want to use a triplet, you want to use at least 2 new drugs. You want to keep in mind some patients are still eligible for transplant and consider transplant, and keep in mind clinical trials for patients. I'll move to smoldering myeloma. There's a lot of excitement in this field. This is an abstract that was presented at ASH this year by the iSTOP-MM, the Iceland Stops myeloma trial. This is a huge randomized trial in Iceland with over 75,000 people looking at the value of screening. But the byproduct of that is that in the screening arms, they did a bone marrow. And so you know exactly what is the prevalence of smoldering myeloma. So we know the prevalence of MGUS from Dr. Kyle's studies, but no one really knew what is the prevalence of smoldering myeloma in the general population. And what the Iceland group shows is that 0.5% of the general population over the age of 40 has smoldering myeloma. That's 1 in 200, and that's a lot. And so as we find treatments for smoldering myeloma, this is going to be an important area of research in terms of who to screen, when to screen, and what to do if you do find smoldering myeloma. Not all smoldering myeloma is the same. The Mayo Clinic has found that you can take smoldering myeloma and apply certain simple parameters like M spike size, bone marrow plasma cell percentage, and free light chain ratio, and classify about 1/3 of the smoldering myeloma into high risk and 2/3 into low risk. The high risk patients have a time to progression of median time to progression of 2 years. That means 50-50 risk of progression in 2 years. And this is the group that people like Dr. Loniel, myself, Dr. Mateos, we are people who have done randomized controlled trials in this area. All 3 of us are convinced that early therapy is important. And we have a paper coming out in the Lancet Hematology in the next few days that will outline our vision and our recommendations. The IMWG has confirmed that the Mayo 2220 identifies high-risk group. If you have 2 of the 3 risk factors, that's high risk, and those are the patients who might benefit from early therapy. Dr. Mateos did the study, and she showed that early therapy in high-risk smoldering with just lenalidomide alone improves overall survival. And Dr. Loniel found, the Matea study was lenalidomide plus low-dose dex. Dr. Loniel found in the ECOG trial that using lenalidomide alone, you can get the same benefit. Progression-free survival in the smoldering trials was not PFS like in myeloma. This is real progression to lytic bone lesions and renal failure. That's what you prevent. And in the Mayo 2018 high-risk group, the risk reduction is 90% in both the Spanish trial and in the Mayo trial. As a result, if you have a potential new myeloma or smoldering myeloma, if they have myeloma-like defining events, that's myeloma, you treat like myeloma. If they have no myeloma defining events, then they can be classified using the 20-20 into high risk and intermediate or low risk. Any two of the three risk factors makes them high risk. They have a 50-50 chance of progressing in 2 years, 25% per year. Early therapy we recommend with len or lendex based on the Spanish and the ECOG myeloma trials, or you enroll them in a clinical trial. We are doing a clinical trial in ECOG where we are asking the question whether high-risk smoldering myeloma is best treated with just a preventive therapy like len or lendex, or with a triplet like dara lendex like myeloma, and that trial is accruing. Intermediate and low-risk smoldering myeloma patients can be watched. If you have FISH results, you can do a little bit more sophisticated risk stratification using the scoring system that's in Blood Cancer Journal, published by Dr. Mateos. And this has a scoring system based on the free light chain ratio, the M protein, the bone marrow plasma cell percentage, and the FISH abnormalities like DEL17, 414, 1Q gain. And you can see here, there are some patients who have a very high risk of progression, almost approaching that of ultra high risk patients who we reclassified as myeloma. Now, close with MGUS, as I told you, the most important update from ASH is the iStop-MM. We know that MGUS is present in 3%, 4% of the general population. We know that the prevalence increases with age from Dr. Kyle's study. But the question is, should we screen? Should we look for it? The Iceland group is randomizing, has randomized 75,000 people in Iceland over the age of 40. Arm 1, no further workup, which is pretty much like what is going on right now, which is we don't look for MGUS. Arm 2 is if you find MGUS, you screen, you find MGUS, you follow the IMWG guidelines. And then Arm 3 is more intensive follow-up. So this trial will answer 2 questions. Should we screen or not, comparing Arm 1 and Arm 2? And should we really follow MGUS patients closely and intervene if any sign of progression occurs? That's early intervention is being tested by comparing Arm 2 and Arm 3. So very important trial. Results will take a long time to come. But they found right now already that the prevalence of MGUS is about 4%. They also find that, as expected, they are finding higher rates of plasma cell malignancies in the screen group. These are people who were in the non-screening group. Only 9 were found on regular medical follow-up. But this is as a result of screening, they have found more symptomatic. Most of them here, this green is smoldering myeloma, but they are finding some myeloma as well, more than in the screen population. But that doesn't mean they'll have better outcomes. That doesn't mean we should screen patients, but this is an important study. And I hope that the iStop-MM trial like studies show that if possible, we should do some screening in India, like a screening study, not general screening, just to identify at least what is the prevalence of MGUS in India. Is it similar to the white population? Is it double the risk as in the African-American population, or lower as in Southeast Asian population? So it will be something that I hope is carried out in India. I'll close with this. Thanks for your attention and happy to answer any questions. Thank you.
Thank you, Dr. Vincent Rajkumar. That was beautiful. From A to Z, you covered everything, including the advances. grateful to you. We
Thank
have
you.
a lot of Indian faculty here and a lot of attendees, almost 300, 350. They
Perfect.
all must be asking, ready to ask questions to you. But I'm going to begin with my question first.
Sure.
Your comments on the Forte trial and the Master trial.
So, I'm having a hard time interpreting trials where I don't know what the control, whether the control arm is standard, and also if it's phase 2. So I don't want to comment too much on that. I think the Forte trial, the main takeaway for me is that transplant is still important, but the role of carfilzomib will need to be refined in the future.
Okay. My second question is, if DARA has been used upfront, and then there is a gap because there is maintenance with only lead, can we use DARA again during relapse?
Yes, absolutely. I think DARA, what I think the Cassiopeia trial shows is that you get a lot of benefit with DARA upfront, and you don't need to keep on giving it for a long time. But DARA would most likely still work really well after a gap, because the patients are still sensitive to DARA, and it will still work. And most of the time, the relapse is occurring with BCMA, with CD38 expression. So it's something that I would certainly recommend, and you shouldn't ignore that. I think you want to only look at patients who've been on DARA throughout, and now they're relapsing while they're taking DARA. Then you might give a break, but otherwise.
My third question is, if there is T1114 translocation upfront, I'm sorry, other way, if there is no T1114 translocation upfront, then do you still screen it at the time of relapse? Can it develop?
So, we think that all myelomas will have one of the primary cytogenetic abnormalities, almost all of them, and that these developed early on at the MGUS stage. So if you had a 1114, you will always be a 1114. You won't change to a 414. If you had a 414, you won't change. But what happens in the newly diagnosed setting is it depends on how many plasma cells were there for analysis for the fish. And so sometimes you don't pick up the 1114. So it's worthwhile looking for it later on. Let's say if you have a newly diagnosed patient and you picked up deletion 13, you picked up 1Q gain, but you didn't really pick up any of the primary cytogenetic abnormalities. You didn't pick up a 414 or a 1416. Then it's worthwhile looking for the 1114 at relapse, because at relapse you have more plasma cells and maybe you'll pick it up. But if you find it at relapse, it means it was there at newly diagnosed. Your test was not good at picking it up. Now, there are patients with trisomies where it gets a little tricky, because there are patients with trisomy who have an IGH translocation also. Like they have a trisomy of 3, 5, and they have 1114 on top. So in the newly diagnosed setting, if they have a 414, I won't repeat the 1114 later on. But if they have a trisomy, they may have had 1114, you just missed it. So again, because venetoclax is there, it's okay to look for it. But if they have a different IGH translocation in the front line, then I won't look for it in the relapse time. I hope that makes sense.
The other question is again related to venetoclax. Will this be the treatment of choice for the first relapse, or will it be kept for the last relapse?
Great question. I think I don't know what Shaji might answer. I think he led the Bellini trial, and he thinks it's very, very effective and very safe in 1114. I mean, with the Bellini trial, the main concern was that the overall survival was worse in the overall population. It's only in the subgroup analysis that we are finding that the 1114 group is okay. But I still don't see a big overall survival improvement in the 1114 subgroup, even in the 1114, even though the 1114 had a 90% reduction in risk of progression. So I am a little jittery. I think there are so many good options for the first relapse, so that I would use it for second or higher relapse rather than first relapse.
Right. Between these two CAR-T therapies, which are against BCMA, is there one better than the other?
I don't know. It's hard to compare the two because they're two phase 2 trials. If you look on paper, Cilta-cel, which is made by Janssen, is almost double the PFS, double, in response rate and is better in PFS. It's better in side effects. It's about the same. However, the difference could be possibly due to just patient selection. It's hard to say because ide-cel came first. And when we were picking patients for ide-cel, we were really taking patients who had no options, who were hardly, able to tolerate the treatment and treating them. By the time Cilta-cel came, there were a lot of other trials going on with immunotherapy that people were cherry picking the right patient group. So is it really better, or is it better only because of patient selection? I don't know. However, my promise with Cilta-cel is more with availability. ide-cel has been a disappointment with availability. We are hardly able, each big center in the US is hardly able to treat one patient or two patients with ide-cel each month. They just are not able to manufacture. So we're all eagerly waiting for Cilta-cel, where we think we might get 6 or 10 patients a month that we can treat. So I think time will tell. Once we start using it in real life, we'll know whether the PFS is truly 2 years or not.
Right. And the results of bispecific, how do you compare them with the CAR-T? Are they matching or they are inferior?
Again, because it's different patient populations, hard to say. See, with CAR-T, because it's going, I see a patient today, I think they're good for CAR-T. I'm going to only pick patients who are responding to therapy, who can wait for 1 month for me to, get all of the things in order to do the CAR-T. So they are self-selecting the patients. Whereas with bispecifics, it's off the shelf, like, I enroll the patient immediately. So it's hard to know whether the higher response, you do get higher response rate with CAR-T and probably better PFS, but surely better PFS. But whether that's due to patient selection or really better, I don't know yet. The advantage of bispecific is you can think of it today and treat today. So it might overcome any difference. So again, only time will tell. It's just remarkable that the bispecifics are giving you double the response rates of the other older myeloma drugs, which are good drugs. So I'm hopeful.
Thank you. Dr. Stalin, your question.
Yeah, thank you, sir. Thank you for that very nice talk. My question is, sir, for all high-risk patients, you are considering a maintenance therapy post-transplant with double agent or only bortezomib single agent maintenance? Or we should consider both botil and maintenance for all patients with high risk?
I wish I was saying this recommendation with a lot of data, but it's a lot of, putting 2 and 2 together. My judgment call is that you should do both lenalidomide and bortezomib. That's what we are doing. A lot of it is from Dr. Loniel's experience at Emory, where it's a single center experience, but it's a huge number of patients, like 1,000 patients or something. And they followed this strategy, and the high-risk patients in Emory are doing really well. And they routinely do like VRD maintenance. I don't think the steroids are important that much, but they're doing doublet. So that's where it's coming from. There's also some data from, I think, the UK trials, which show len maintenance also works in high risk. It's not like that it doesn't. There's data from the whole one that bortezomib maintenance works. So we just, with the high risk patients, we just don't want to take any chances. We want to try and get the deepest response possible and maintain it for longer. So we are doing both. It's pretty well tolerated. We know that from many of the trials that you can use bortezomib and len together for a long time. So that's why I do recommend both rather than just one.
Okay, sir. Sir, if a patient received a VCD as an induction therapy, So post-transplant, yeah, ideally the maintenance should be the drug which was used as a part of induction, or can be an alternative drug like Len can be chosen as a maintenance then.
Yeah, and again, years ago, this was a big problem for us because a lot of us, even at Mayo, were using VCD for frontline. And then we were stuck, what do you do after the thing? We are going by the maintenance trials with the data from the maintenance trials that they use, Len maintenance. If you look at the BMT CTN trial, they had any induction and then they used Len maintenance, and they found it worked quite well. So even though, yeah, your logic is that they got VCD, it'll be nice to keep doing the same. We think too much alkylator for too long is not a good idea. So we are happy to go with the data that we have from the maintenance trials and use Len instead, even if the patient got VCD or something else.
Thank you, sir.
And that's why, for the high-risk patients, if you look at my algorithm, there's nothing wrong with using DARA, but for high-risk patients, I'll use VRD or DARA VRD because when it comes to the maintenance, I don't want to use DARA RD for frontline, for induction, and then for maintenance, use bortezomib and lenalidomide. I mean, I'm switching the whole thing. So either you use DARA VRD or VRD, and then you'll be continuing the same.
Thank you, sir. Thank you.
Dr. Vincent, when you're using double agents for maintenance, even Velcade continues till the relapse, or you stop it somewhere?
So, the HO1 trial just gave it for 3 years. So we say at least 2 or 3 years, but it really depends on how well the patients are doing. I mean, if they're having neuropathy or something like that, then after 3 years or 2 years, whatever time, you may have to stop it. If you really think they are high risk and, because you had a problem with getting them into the CR in the first place, and then you could switch to carfilzomib maybe and try to use carfilzomib in a maintenance schedule if neuropathy is what's causing the problem. But I try to continue it as long as the patient's tolerating. I have given it for as long as 10 years, the bortezomib, but not every other week. At some point, it becomes like every 3 weeks or every other week, then give 2-3 weeks gap, something like that.
Dr. Neeraj, your question.
Thank you, Professor Rajkumar, for that excellent talk. My question is regarding MRD. Outside clinical trial, do you use MRD in clinical practice? And if so, I was just curious whether the treatment of a high-risk patient who becomes MRD negative at the end of induction, how would you do that? Or a low-risk initial patient or a standard risk initial patient who becomes MRD positive at the end of induction?
Yeah, excellent question. I'll answer, but please don't post my answer on Twitter or something like that. I generally, and many of my colleagues, generally, we don't do a bone marrow just to make sure the patient's MRD negative. So if the patient is in CR and stringent CR, we leave them alone. Because I know that MRD is a prognostic factor, but that much anyone knows. And so I'll start off by saying, what are the 4 ways in which you use MRD and what do we have proof on? We can use MRD to tell patients the prognosis, how likely they are going to relapse. If they are really keen on knowing the number, then MRD data show prognostic ability. You can tell them based on the result what they're looking for. So that's proven beyond doubt. And but all my patients, some of my patients don't really want to know if they are in stringent CR, whether the PFS is likely to be 5 years or 6 years. I mean, it's going to be a long time. So they're happy with that. But if they want to know, that's a proven indication, you can do the MRD test. The second question is what you asked. What do you do with the result? If it's negative, do you stop therapy? If it's positive, do you add therapy? That is not proven. That is still an experiment. and it can only be answered by a randomized controlled trial. And so there are randomized controlled trials ongoing, including one that Dr. Shaji Kumar is leading called the Optimum trial, where you do an MRD test, and using the test result, you randomize the patients, and you're hypothesizing that, the positive patients, escalating therapy is beneficial. For the negative patients, de-escalating therapy is beneficial or gives the same result. And only time will tell. Right now, we don't have data that doing something with the MRD result is going to give you a better outcome. We think it might, it's a hypothesis, but it's not proven by phase 3 trials. The third way you use MRD is, can I use MRD instead of PFS or overall survival to get a drug approved? And this is a question that pharma is interested in, because they would rather not wait 4 years, 5 years for the study result. They want to get the MRD result in 3 months or 6 months and show to the FDA that my MRD rate is different. This is a surrogate for survival, so please use this instead and approve my drug today. That also has not been proven. That is something that does not, you cannot use the current studies to interpret that. You need to do what is called a surrogacy analysis, where you take a number of randomized trials that have looked at MRD, PFS, and overall survival, and you show that the change in MRD correlates to the change in overall survival or PFS. That when the MRD rates are different, the PFS is different by about the same amount, and the delta is correlating. And that surrogacy analysis is ongoing, and this is what the I-squared team is trying to do, pooling data from a number of randomized trials. And if it's proven, sure. But you remember in oncology, there are very few surrogate endpoints that have been validated like that. Hodgkin's disease, there's the CR rate, the diffuse large B-cell lymphoma, adjuvant therapy for colon cancer. There's some where the surrogate has been validated, but for most oncology, surrogate endpoints like MRD have not been validated. And the fourth use for MRD is to tell patients whether they are cured or not. Like if you're negative, the patient's asking me, am I cured? What is the chance I am cured? And that only long-term follow-up will tell you. And you will need to know what depth for how long is equal to cure, like we know now for, say, Hodgkin's or DLBCL. So that also is not proven. So that's where we stand. We know that MRD is a prognostic marker. So if the patient's really interested in knowing their specific prognosis, by all means do it. If the patient is not that keen, then it's only for our own sake that we are doing the test. Using MRD for changing therapy is not proven. But your question is great. What do you do with these high-risk patients? I'll give you other people's opinion because I'm not the only one who can have an opinion. So Dr. San Miguel feels that if high-risk patients, he does do the MRD test, and if they're positive, he does change the therapy, because he's convinced that high-risk patients, the risk is just too high if they are MRD positive, and that he's going to try his best to make them MRD negative, which means escalating therapy, which means adding toxicity, but he thinks it's worth it. So if you are in that philosophy, you might want to do the MRD testing in those patients. There's a SWOG trial going on because some patients ask, Doc, I'm really like MRD negative. I want to stop the treatment because it's having a toll on my life. And we want to know if stopping maintenance after a year is enough. And so some people are convinced that that might be a good way to use it. And so if you're convinced about that, you could do it, but I'll wait for the RCTs for that. The other two indications like surrogacy and for cure, data is still not out. So that's where we stand. At the end of induction, I think the most important thing that I want to tell people is that there are some centers which are saying to patients, oh, you're not yet in CR, so I won't do the transplant yet. Go some more induction, and then I'll do the transplant. That's a mistake. We have not established the value of transplant by those kind of studies. The value of transplant was established by studies which gave 3-4 cycles of induction, and no matter what the response was, they randomized them and took them to transplant. The transplant itself is the treatment if your induction is not working well. So trying to get the deep response is only something that a curative treatment would do, like in AML or DLBCL. So, but not for myeloma. So I don't look at the MRD result pre-induction or post-induction, post-induction or post-transplant to do anything big with that result.
Thank you very much.
Thank you. From that token, if a patient gets biochemical relapse, then should one rush with the treatment because it is beyond even MRD?
Yes, and I will tell you what we are doing for research. So at Mayo, again, as you know from the smoldering trials like the ASCENT and the CAESAR, we are going for curative approaches. We're having a hypothesis that if you hit hard and early, you can cure it. Some of the people who are advocating for the quadruplet, like Dara VRD, are thinking, man, if we do this 4 drugs from the beginning, there might be some patients who are cured. And that's the hope with which they are like really passionate about the 4-drug treatment. Time will tell. A lot of relapse patients ask me, does it mean that at the time of relapse, there's no chance for cure, so you're just going to give me some triplet and prolong my life by a few years? Or is there any chance of cure? So at Mayo, we are doing some studies, or we want to do some studies where we're taking even an MRD flip or a relapse flip and see if you can give intense therapy. And the hypothesis being, can you cure even patients who are in early relapse with all the tools we have? Is it possible to cure some patients? And so that studies are ongoing for research. In clinical practice, for high-risk patients, we are treating even at biochemical relapse. If we think biochemical relapse, I would treat. For standard risk patients also, if they meet the IMWG progression criteria, I think it's probably better to treat them. And that's based on the fact that when the IMWG criteria were developed, like a 25% increase in M spike, at least 0.5 gram is progression. The FDA and other agencies wanted to know, because we are approving a drug based on that number, how reliable is this number? How good is this number in predicting? And early on, Dr. Blade and others found that patients who get that kind of progression, if you don't do anything, 3-4 months later, they will get a lytic lesion or they will progress with a myeloma defining event. So these are real progressions. And if you just watch it, they will probably get a real end organ damage type of event in the next few months. So if it's a minor CR becoming not a CR, that's one thing you can watch. But if it's a true 0.5 gram increase, I would just, with today's treatment, just consider it progression and go to treatment.
Thank you. Thank you so much. Dr. Aditi.
Good evening, sir. So my
Hi.
question is for a solitary plasmacytoma of bone with minimal bone marrow involvement or a smoldering myeloma, both of which we are considering observation alone. When would you suggest to do bone marrow in these cases in absence of any biochemical or symptomatic progression? Do you want to repeat bone marrow in these cases in future?
Yeah, great question. And I'm sorry if I give a long answer. Number one is, I think this question of solitary plasmacytoma, I'm thankful you asked, because I'm sorry I didn't cover it. We changed in the IMWG criteria in 2014. We split the solitary plasmacytoma into 2 groups, as Dr. Aditi mentioned, into solitary plasmacytoma and then solitary plasmacytoma with minimal marrow involvement, because they too are quite different in how they behave. If you have a true solitary plasmacytoma with just 1 lesion and the bone marrow is 100% normal with no clonal cells, then radiation alone can cure a lot of these patients, 80-90% of these patients. So that's a very different condition than if the bone marrow is involved. If the bone marrow shows clonal plasma cells, if it's more than 10%, they will become like myeloma, so it's a different category. But if there's minimal marrow involvement, 1 to 9% involvement, boy, that's a very hard group because there's no data. What we know is that they will progress, like 60% will progress within 3 years. So you have to be really careful in watching them, because otherwise the progression will be with another plasmacytoma, which could occur in the wrong place, like in the spinal cord or somewhere else. So we want to be careful with these patients. They're already proven to you they can cause problems. So we are recommending really careful follow-up. Many of them, we are still doing only the local therapy and then watching closely. I look at how much they are secreting at the time of the diagnosis. If they are secreting substantial amount, then hopefully after your radiation, most of it will come down. And then you can just watch the biomarkers to see if they're relapsing. But I still would do a PET CT or something like that once a year to make sure that there's no lesion that's coming up. I won't need to do a bone marrow. But if they are oligosecretory to start with, and or non-secretory to start with, and there's not much I can believe the secretion, then depending on how aggressive the plasmacytoma was, the initial one, if it was a big one in the spine or something like that, I'm really scared. Then I would repeat the marrow in a year or two to just make sure I'm not getting into the myeloma territory now. So definitely repeat the marrow in those patients. In others, you could watch them with PET CT and with the biomarkers. For smoldering myeloma, because most of them meet the smoldering myeloma category by having the high-risk category, using the high-risk category, I really, like I told you, I really want to treat because I'm too scared to watch. So we are recommending Len or Lendex, in which case we are watching them, we are treating them. Most of the time the M spike comes down. And so if they relapse, you don't need to do a marrow all the time, because you'll find out, oh, they're relapsing even though they're on lenalidomide. So it must be a real relapse, and we can. But if you're just watching them and they are low risk, again, depending on how unsure I am, I would do the marrow. If anything is not correct, I do the marrow. But most of the time, you are okay with just the M spike, the light chains, and you'll be fine with watching the low risk with the biomarkers.
Sir, for biochemical relapse in solitary plasmacytoma of bone, post-treatment, if the patient's kappa lambda chains were never normalized, the criteria are quite stringent. That 25% increase in the difference between uninvolved to involved is very easy to get sometimes, is what I have seen in one of my patients. I have been observing her closely, but do you feel for this case also, for a solitary plasmacytoma of bones, a biochemical relapse should be treated?
It's a great question. I think, let me tell you, because the solitary plasmacytoma with minimal marrow involvement, 1 to 9% plasma cells, there's really no easy way. If they have more than 10, I'm happy to do the treatment and not worry about a relapse. Our treatments are not that dangerous, and you can give them. But this minimal marrow involvement patients, we try to do a randomized trial because a lot of us were nervous about these patients. After all, we are recommending early therapy for smoldering. And then we are saying, just watch this patient who's already proven themselves by getting a lytic lesion or a soft tissue mass. So we proposed a trial with triplet versus adjuvant with observation. But unfortunately, the population is so small that we could not accrue patients, and the trial closed after 2 or 3 years because it didn't accrue enough patients. So I think this is something, because India is a large country, you do have the population, you're the only country that can probably answer this question. Take these minimal marrow involvement patients and really newly diagnosed, radiate, and then give adjuvant therapy with the triplet like VRD for 6 months or something versus nothing, and see what happens in terms of progression risk. And it's easy trial to do. If some of you join together, you can pull it off. So have to select the patients carefully. But let's say, like your patient, your solitary plasmacytoma, minimal marrow involvement, or just even the just regular solitary plasmacytoma, and you're watching and the M spike is going up or the light chain is going up, I get very, very nervous. I have personally had patients like the ones you've described, and I personally treated them. If I get nervous, I treat because there's no data and you have to use your gut feeling. And your patient is your important person to protect. And so I really talk to the patient and I say, like, I have absolutely no idea what to do. There's no data that's going to guide me. Your M spike is going up and I don't like it. I cannot see anything new on your PET CT. If you're happy, I can give you 6 months of VRD and see how it goes. You have to play it by the ear. There's so limited data, but I do get very nervous with these patients.
Thank you so much.
Thank you. Dr. Jeevan?
Thank you, sir, for the wonderful talk. So I have two questions. The first is if a patient, relapsed refractory myeloma patient on daratumumab maintenance, and patient is in CR on the myeloma side. Now patient presented with multiple infections, and we have done immunoglobulin level test that is low. So any guideline that we have to give IVIG to the patient, or we can increase the duration of daratumumab maintenance from 4 weeks to 6 weeks? Any such trials are there, sir?
Yeah, I don't know the data, but I am worried about these long-term risks of DARA. It is a very powerful drug in suppressing normal plasma cells also, not just the myeloma plasma cells. In fact, that's why we are planning on doing studies in non-plasma cell disorders with DARA, just like rituximab, for like autoimmune conditions and things like that, because it really suppresses the normal plasma cells. We see that with the COVID vaccines. It's normal plasma cells that make antibodies against COVID vaccines, and they are suppressed. So I think it's very reasonable to do IVIG if your patient's getting recurrent serious infections to protect them, and it will work. In the US, IVIG is a cost issue. So it depends on the cost there, but I think that would be reasonable. Prophylactic antibiotics, I think we are all doing Bactrim for PCP. Hopefully that alone will protect from some of these infections, but those are two options for you for preventing recurrence infections. You could consider delaying the infusion. I wish we had data. The Pollux trial basically gave data forever till they progressed. So it's hard to recommend, but and I don't think if you go from 4 weeks to 6 weeks, I think the effect of DARA is so prolonged that even if you go every 6 weeks, you will still have a low immunoglobulin levels.
Thank you, sir. And one more question. So the patients which are refractory to daratumumab, carfilzomib, pomalidomide, what is the data of elotuzumab in these patients? If we are using first line as a daratumumab, or if we are using it as relapsed refractory myeloma?
Yeah, I'm telling you, again, as much as the good treatments we have, we can quickly use them up. You can do DARA VRD or VRD and then do DARA KPD, and you've used up all of the good treatments just in 2 lines. And then you're stuck. Because I don't know that elotuzumab or ixazomib or any of those drugs will work well in those kind of patients who are refractory to DARA, to carfilzomib, to pomalidomide. So DARA KPD progression is really bad news because you've used up 4 of the best classes of agents, like right there. If they're 11, 14 venetoclax, I still think alkylators are a good idea, and keep in mind, I have encountered some of these patients, and the 2 or 3 strategies I've done is KCD, which sometimes work even if they are PI refractory. Just do cyclophosphamide 500 once a week oral. Or I've used melphalan, IV melphalan. IV melphalan, data is very limited. The usual melphalan prednisone that we used to use, if you gave it IV, it'll be about 16 milligrams per meter squared, once every 4 weeks. It actually works well. But I have done more like 25 per meter squared, which is not myeloablative, but pretty powerful. And so KCD, IV melphalan, putting together some combination regimen. Here we have selinexor and some other things that we can try, but I don't think many of these drugs will work in the type of patient who's truly refractory to DARA KPD.
Thank you, sir.
Thank you. Dr. Verma?
Thank you, sir, for the nice talk. Just wanted to know the treatment of extramedullary relapse of myeloma, both in those who are transplant ineligible and in those who have got the transplant and then relapsed at the extramedullary site.
Yeah, I think extramedullary relapse is not a good thing. It is very, very similar in my mind. I always keep in mind it's like plasma cell leukemia, because these patients don't do well, and it tells you this is aggressive disease. I mean, we have to really do something about it. And even though it's 2022, we still do VDT pace. If it's just one small soft tissue lesion, that's not what I'm thinking you're calling extramedullary relapse, but it's like multiple extramedullary sites and or plasma cell leukemia, then 1 or 2 cycles of VDT pace to get the stuff under control. And then you do your triplet. So that way you can control it and keep it under control. And then after some months, it'll probably not work. And you may have to do again the same 1 or 2 cycles of VDT pace and then go back to some other triplet.
Sir, here in India, in relapse settings, we are much more compromised when our patients are not affording treatment. So, what is your take on use of bendamustine in such situation? Whether any protocols with bendamustine which can be useful for relapsed myeloma patients?
Yeah, I mean, I have suggested bendamustine to patients in India who I have helped. It's hard to say because we are always using it when like nothing else is working. So my experience hasn't been that good. But certainly bendamustine with bortezomib or bendamustine with lenalidomide or bendamustine by itself is worth trying. And if it's not that expensive, it gives you the same alkylator type effect. That's all I can say.
Yes. Thank you, sir. Just one last question. Where you put selinexor, because it's an oral drug, where you put selinexor in the treatment line, whether at the time of relapse?
It'll be like the last hope kind of thing. I'm not using it that much. The problem with selinexor is, and I have told the company this also, you can't believe selinexor dex alone because it's single agent. And so you could try it, but its response rate is so low. Selinexor bortezomib dex, they say it works well, but how many patients do we see in relapse who are still sensitive to the PI? They're already refractory to bortezomib by the time they get to that stage. So it's just like giving selinexor single agent when that time comes. So it's another hard drug. It's like selinexor, elotuzumab, they're all going to struggle when immunotherapy really takes off. If you want to try it like once a week with bortezomib and see if it works, and be prepared for GI side effects.
Thank you, sir. Thank you.
Subha Prakash. Sanyal, are you there? Okay, Priyanka.
Good evening, sir. I would like to hear your experience of renal transplant in myeloma patient. There are some good risk patients who are having a long-term remission, but their lifestyle is compromised because of the renal replacement therapy.
Yeah, great question. And, I don't know what the situation in India is, so I think you will have to make the decision. Here, the main problem in the US is that the transplant centers are all evaluated on 1 year, I think some graft success rate. And they're all hanging by a thread, like 95%, 93% or something, they have to have that. So most of the transplant people don't want to take myeloma patients because they feel like if they could lose their accreditation if they transplant myeloma patients and the myeloma progresses or they get into renal failure or something like that. So they don't want to take any risk because they're so narrow. 1 or 2 patients could lose their accreditation. If you don't have any such concerns in India, because you have different standards or I don't know the situation, then if the patient is in CR or MRD negative after newly diagnosed disease, and you've got them into the MRD negative or CR, then you really have a lot of data that they're going to go at least 3-4 years before the relapse occurs. And until the relapse occurs, there's no risk to the kidney. So if you're able to, you could potentially transplant and give them better quality of life. But your real thing is like, make sure that they're MRD negative, preferably, or CR, really stringent CR, and quite close after the initial therapy, standard risk, not likely to relapse in like the next 3-4 years. And then that's the group of patients you can possibly go to. With amyloid, it's been a little bit easier for us to do the renal transplant because we show the transplanters that amyloid is not a malignancy, that if the kidney is the only organ involved, then if they do a renal transplant, we can do a stem cell transplant after the renal transplant. And we'll assure them that it won't come back. And so they have been willing to do it. With myeloma, it's been a little bit more tricky.
Even sir, monoclonal gammopathy of renal significance patients, like
yeah, and
they have only renal involvement.
Yes. So monoclonal gammopathy of renal significance, I think if I have the opportunity, I will tell you, please remember that it's like a heading of a book chapter. It's got a number of unique diseases in that category. And really the treatment will depend on which of the monoclonal gammopathy of renal significance are we talking about. Are we talking about light chain deposition disease? Are we talking about C3 glomerulonephritis? Are we talking about membranoproliferative glomerulonephritis? Which of the which of the MGRS diseases are we talking about? And so the renal people are very familiar with which of those are likely to recur in the transplanted kidney and all of that. So they have to collect data not for MGRS as a whole, but for each individual disease. Light chain deposition disease, it's a little bit more easier to decide than some of these other ones, which are all new and we don't have that much data on. So I think it really depends on the specific disease and what the transplanters know. What is the probability of a membranoproliferative GN with renal failure coming back in the transplanted kidney? And part of the problem in the US is we are not able to treat these patients like myeloma with the myeloma-like drugs because they're all just so expensive and not covered. This patient's got MGUS, and we can't promise that we'll eradicate the M protein because we may not be allowed to eradicate the M protein. The drug's expensive. So it makes it a little difficult there. And I think, again, these are all opportunities for research. But again, be careful, though, that to whatever data is described, it should be described as we took 100 people with C3 glomerulonephritis cost associated with the monoclonal gammopathy and what happened. Not for MGRS as a group, because that's a collection of different diseases.
Thank you, sir.
Thank you. Dr. Shinto.
Thank you, sir. Thanks for this nice lecture. I have two questions, two transplant-related questions. One is the melphalan dose, 140 versus 200. And the second one is the role of tandem transplants in today's era.
Two great questions. So, with the dose, we are usually defaulting to 200 per meter square. That is our usual default. The 140, I think at Mayo, they're using only for elderly people like, 70 plus, or patients who have renal failure that they feel like they cannot give the full 200 to. So that's basically what, and Shaji would be a better person to do that because I don't do the transplants, and any of my patients, I counsel them whether to get it or not, and then hand them over to Shaji. But then with Shaji, usually we both are arguing. I am trying to give my patient the lower dose and he wants the higher dose, just so you know where we are. So he will tell you 200 default, like almost everyone, and then 140 for thing. For the tandem, the data are conflicting because the US trial, which looked at 1 versus 2 transplants in the modern era, showed no benefit for the second transplant. But the European trial did show a significant survival benefit with the double transplant, particularly the higher risk patients. And for me, I think the way I interpret it is that if there are multiple options for relapse, at the time of relapse, if you have a lot of treatments to offer, then the second transplant doesn't seem to add that much. So that's the US situation. But if the options for relapse are limited, then the tandem really helps you because it gives them a longer PFS, and they don't need the relapse options as much till very late. And so that's why the European trial is positive. So higher risk patients, less options for relapse treatment, look like deletion 17p414. You can consider a tandem for young people if you don't think they have too many options for relapse.
Thank you. Dr. Afa?
Thank you, sir.
Thank you, sir, for a wonderful talk. I have two
Thank you.
questions. One is, how will you treat as myeloma with CNS disease? And second is that how often do you do regular PET CT scans on follow-up of a myeloma patient? There might be a situation where around 10 to 12% of patients might achieve a morphological CR, but on PET CT, they might show progression. And that is the subset of people we have to deal with. So what are your thoughts on that?
Yeah, great. I think the IMWG published some consensus guidelines on imaging. I'll tell you what I do on the PET CT first. If you can do it, I would do it. If I had myeloma, I'll get a PET CT every year. Because the only barrier is the cost. In the US, the only barrier is whether they will reimburse it. There's so much relapse we see sometimes that is not picked up on the M-spike and the free light chains. And with all the options we have, I truly believe early treatment would control these things quickly. So I am with you on that aspect. The main problem is the cost, and in the US, the reimbursement also. And so depending on your patient, you'll have to judge. You could do it maybe every 18 months or so. At Mayo, we feel a little bit more comfortable because our institution has changed fully to low-dose CT. They don't do skeletal surveys at all. We only do low-dose CT. So even if we have a reimbursement issue for PET CT, all my patients are getting a low-dose CT every year for follow-up. So that picks up every time I order a skeletal survey, they get a low-dose CT, the whole body. In terms of CNS disease, is really nothing, zero. I basically tell them like most likely supportive care, palliative care. I don't think radiation will work. People have said DARA and selinexor might work, pomalidomide might work. You can try it, but not much.
Thank you. Cecil?
Yeah, Vincent, the point is that you raised a lot of questions that most of the questions that are unanswered can be done in India and be very useful to do that in India. But, I want to actually ask a few good men in this seminar, as well as Dr. Agarwal, that how many of us would be happy to, or would have the wherewithal to do an investigative-driven study with the insurance, with the patient support, with the IEC, with the DCG approval, and so on and so forth, to be able to mount a study, even if you are interested and if you've got the numbers. It's not an easy task with the current atmosphere. I know what Dr. Agarwal would say. investigator-driven study without funding.
Dr. Vincent, you're there?
Yeah, I'm here. I think he was looking for your answer first.
Our session will discuss it separately. There are 4 minutes left, and I see Dr. Anant Gokarn still has a question. So I'll discuss session with you later on. Anant Gokarn.
Yeah, I would like to ask in solitary plasmacytomas, is there a role of doing a FISH on the tissue of the plasmacytoma to see the risk of progression? Is there any data on that? Can we do that?
Yes, you can. I think they have to decalcify the bone if it's a bone plasmacytoma to do this. But our lab has validated those tests. I usually am not able to order it even at Mayo Clinic. I have to call the pathologist and tell them, see, I have a solitary plasmacytoma. This is not a bone marrow biopsy. You'll get a bone biopsy and you may have to decalcify and all of that. But I really, really need the FISH. Can you please get it on? And they've been able to get it for me.
And do you act on those?
Yeah, go ahead.
Do you change your treatment based on what you get on that?
No, it's just like I think one of the physicians was asking me about solitary plasmacytoma follow-up. If I think I have a 17P or a 414 on that biopsy, I'm really worried about relapse because, as you know, we just talked about smoldering myeloma. Smoldering myeloma is like in the spectrum. You have MGUS, you have smoldering, you have solitary plasmacytoma, and then myeloma. We are already telling that the high-risk smoldering myeloma, you should do LEN or LENDEX. So when I have a solitary plasmacytoma patient who has already demonstrated they can destroy bone, and they have high-risk features like 17P or 414, if I only radiate it, I'm worried that it might come back. So the result will help me decide how aggressive to watch for the relapse and what would make me change my mind and start treatment after discussing with the patient. If they have 5 or 7% plasma cells in the marrow, then I'm now already looking for an excuse to treat. So I might be, if their M spike starts going up, I might tell them like, please, let's do a bone marrow. Let's see if it's 10% and I'll see if I can start therapy for you. So it might help you with how aggressive you follow them.
Thank you.
Thank you, Anand. 4 raised hands are there, 8 questions in the question box, 2 in the chat box. No time left. I have to thank Dr. Vincent Rajkumar. 2 hours. We have grilled you and you patiently answered. Phenomenal. Patiently answered, elaborately answered, and very convincingly answered everything after a great talk. I think next time we call you, we'll have to have you for 3 hours. That's
no problem. Please feel free to email if there's questions.
Yeah, please. Those who have left out, I'm very sorry. Please email to Vincent. And if you don't have the email ID, I'll send it to you.
There you go.
Thank you so much. Have a wonderful day.
Thank you, everyone. Have a great night.
Bye-bye.
Bye-bye.
Thank you, sir.
Move on to the second lecture of the day. I've already introduced Dr. Dabaja, but just briefly introduce her again. She's Professor, Section Chief of Hematology, Department of Radiation Oncology, University of Texas, MD Anderson Cancer Center, Director of Research, International Lymphoma Radiation Oncology Group, Houston, Texas. So over to Dr. Dabaja. You have been a regular speaker. You have obliged us multiple times in past. You were here in Mumbai also, and we have again bothered you today with another lecture and request. Thank you so much for being with us.
Thank you so much for giving me the honor. I hope you can see me and you can see my slides. I'm going to make it in a mode presentation in a second.
Yes.
Great. Again, thank you so much for giving me the honor. It always brings a smile to my face when I'm talking to your audience, because I always remember the great questions that they ask and how knowledgeable they are. So it is always a great conversation and communication with your team. So today I'm going to be talking about the evolving role of radiotherapy in hematological malignancies. My disclosures, I have a research funding from Seattle Genetics. These are my learning objectives. I'm going to go through 4 set of new development or new way of how we manage with radiation therapy, starting with how we lower the dose across most subtypes, and that more is not better, going to how we use technology, and all of you are aware of how important technology is by virtue of this virtual communication that we're doing from across the world right now, and that we have a role to play in leukemia and transplant, and then finally how we can prime the immune system prior to either immunotherapy or cellular therapy. So starting with more is not better, where does that come from? From the fact that radiation oncologists, when they treated all sites of disease. So they always wanted to follow same dose to all the tumors, and treating breast cancer and lung cancer is completely different than when you treat hematological malignancies. And it took, unfortunately, several decades for radiation oncologists to get to the knowledge that we really don't need a high dose of radiation, and you will see it in several entities, starting from a simple low-grade lymphoma like mycosis, like multiple lymphoma, or going to a lymphoma that you co-live with for many decades sometimes. Therefore, you really need to be careful about the dose of radiation that you give, and even ending with high-grade lymphoma and Hodgkin's lymphoma. So I will give you a series of sites to show you how important it is to give a low dose radiation. Just to give you an idea before we start, if you're treating a breast cancer, you usually give 60 to 60 gray. If you're treating a lung cancer, you might give up to 70 gray. If you're treating a head and neck cancer, you might give to 70 gray. So when I mentioned 4 gray, you can imagine how low that dose compared to what we give in solid tumors. Starting with the salivary glands patient that presented at a young age, you gave 4 gray, which is only 2 treatments, and you wait on them patiently, and then they would achieve a durable complete response. And that's the most important part of the story, that you have a durable complete response. And as you can see in the publication that we have from MD Anderson, we did publish on just treating the salivary glands when they have multiple lymphoma with 4 gray. Moving forward to orbital lymphoma is the same story. We published on that in this past ASH. We had a presentation from one of my colleagues, Dr. Pinix, showing how a 4 gray only to the orbits. For example, if you take this patient that presented with multiple lymphoma of the orbit with an extensive disease that you can see here when you compare to the other eye, after 4 gray, the patient was in complete remission. I have seen actually this patient over 6 years ago, and I saved her literally from being treated with what we call gamma knife, which is a very high dose of radiation. And she called me from the northeast of the United States just to consult with me. And then at the end of the call, I realized that this patient is going to receive almost 15 times the dose that I was that eventually I gave her. So I told her to completely drop everything and start running out of that clinic, and then I sent her somewhere where she could take only the 4 gray. This is also valid for cutaneous lymphoma when it comes to all sorts of B-cell cutaneous lymphoma. And this is an example of how also these patients can respond very quickly to the treatment with radiation. As you can see, this is a 15-year-old boy who came with CD4 small to medium B-cell lymphoma, and this is before radiation. 6 days after radiation, they melt. 15 days, you can barely see anything. And then 6 weeks after radiation, there is only the scar, and we published on that too. This is no different for mycosis fungoides that patients live with for decades. The key is always to wait and be patient. Don't rush into saying that, oh, I did not see the response, because the body needs to heal by second intention. And again, since when you're dealing with low-grade lymphoma, the lymphoma is not going to jeopardize the outcome or the survival of these patients. So it is very important to wait. And you can see here that the patient presented with this lesion in the ear. I gave her only 12 gray. That was at the time that I'm just dropping the dose, because over my tenure at MD Anderson, I personally dropped the dose from 36 gray to 30 gray to 24 to 20 to 12 to 4 gray, and waited on her. And this is also valid for when you give total skin electron beam in mycosis fungoides, where regularly now we give 12 gray as opposed to 32 gray, which was the kind of a treatment that we used back in the 70s and 80s. And this is a multi-institutional effort that is published down there by lead author, Dr. Hoppy from Stanford. Moving to something that probably 20 years ago, none of us thought that we would get there, which is mantle cell lymphoma. At the time, we used to treat it with a very high dose, thinking that mantle cell lymphoma is a very aggressive leukemia-like lymphoma. And as time passed, we realized that there are patients with mantle cell lymphoma that they can live with it for a long time. But we also realized something very interesting about mantle cell lymphoma, that even when they are relapsed refractory to multiple lines, and they come to us because of a pancytopenia and a low bone marrow reserve, when we give them only 4 gray, which is 2 treatments, as you can see here, a mass in the throat, and after 4 gray, how it completely vanished. We came to publish our paper in Blood Advances. Actually, it came out the month I came to Mumbai 2 years ago, prior to the pandemic. And we showed that a low dose of radiation, ultra low dose of radiation in mantle cell lymphoma will help you keep managing these patients and giving them a low toxicity with the radiation. It's no surprise that we treat LP Hodgkin's lymphoma with radiation, but I had the ability to follow one of my patients who presented with an axillary LP Hodgkin's lymphoma. And this is at presentation, as you can see, up and down on the right side. And as we go through the mid-treatment, because we scan them every day since we ask them to hold their breath, you could see how it melted in front of our eyes. So then we asked the question, should we still give LP Hodgkin the regular 36 gray that we used to give, and specifically that LP Hodgkin probably in the future should not be lumped with Hodgkin lymphoma. It should be moved to non-Hodgkin lymphoma for all the different presentations that mirrors follicular lymphoma, also the late relapses that they might have, which also mirrors follicular lymphoma. And then we published this paper from MD Anderson also showing that we can drop the dose safely to 24 gray, and I would not be surprised in the future that we drop it further. With the reason we chose 24 gray, because that's now the standard of care for follicular lymphoma. I wanted also to show you this case where you are seeing a primary anaplastic large cell lymphoma. This is a patient that came to one of my colleagues in transplant after having this axillary mass that was super ugly and failed to respond to CHOP, DAP, EPOC. And the reason I saw this patient, because he was going through transplant and they needed to render him in CR before transplant. And as soon as I started the radiation, as you can see here, this is pre-radiation, and you can see the large mass in the axilla that completely melted. More than 75% was gone by mid-treatment. And again, his wife was a very careful lady who every single day for 5 months, as you will see here, took a picture of his ulcer healing over time and putting 2 quarters there just for reference about the size. And 5 months later, the patient completely healed. And we went back and forth with our colleagues in transplant not to transplant him, and finally they did not transplant him. He is in remission right now with no evidence of disease for 3.5 years. I'm watching him like a hawk just to prove that you can actually give these patients radiation therapy, and that's all what they need. Moving to follicular lymphoma, we again dropped the dose of radiation from 45 gray that we used to use back 4 decades ago to 24 gray, but we also dropped the size of the field that we used to use. In the past, if you would have a follicular lymphoma in this area, you would always say, oh, I want to go with 1 field above and 1 field below. And that came from the Hodgkin data, where you think that you can predict where the disease can go, since Hodgkin can go in stages. But then that does not make sense for a non-Hodgkin lymphoma, because you can never predict when is the next node that is going to be involved. So a major development in how we treat follicular lymphoma, if you are dealing with a stage 1, 2, which is localized disease, is to drop the dose to only 24 gray and only chase with your radiation field, as you can see it in red here, the area where the disease is. Moving to multiple myeloma, that's my baby, because over the years, it took probably 15 years until I convinced one of our residents to go ahead and review 1,500 sites and to prove that whenever you treat multiple myeloma, one, you do not need a high dose of radiation. They respond to a very low dose. So we dropped the dose to 20 gray and not at 3 gray per fraction like it is used around the world. And the second thing is never to chase a disease that you do not see, because multiple myeloma obviously is in the whole marrow, and you want to save every single bit of the marrow for the treating oncologist not to end up with pancytopenia. And when we published this paper in Hematologica, we did prove that if you give that low dose of radiation, the risk of re-irradiation is only 2.6%, so there is no point to give a higher dose. Even when you're treating a myeloma or a multiple myeloma that completely destroyed the vertebral body, and quite often people would say, I want to give a very high dose so it would not come back. Well, you can never prevent multiple myeloma from not coming back wherever it needs. And then if you treat an area in the spine with a high dose of radiation, you can never come back with another field in a neighboring structure or a neighboring vertebral body. And you can never guarantee that the patient is not going to come back with another lesion. Therefore, it is in our best interest when we give the dose of radiation to be able to come back and treat next to it without compromising the spinal cord. And lastly, even in high-grade lymphoma, we got to a point to drop the dose. So originally, we used to give 45 gray, even 55 gray. For those of you who remember the studies from ECOG and SWOG, there was a dose of up to 55 gray that they would give to partial remission. So this dropped to 30 gray. And this is like a typical example of diffuse large B-cell lymphoma, where you have a large abdominal mass, went away after chemotherapy, and then we come and treat it with radiation. I will touch on the technology later on how you can paint the dose, as you can see it here, in the residual area where the tumor used to be, and how to avoid the kidney with the lowest dose possible, avoid the liver, and avoid the spleen, because you could cause lymphopenia if you do not avoid the spleen. And nowadays, as part of our International Lymphoma Radiation Oncology group, we are running a study between several international institutions where we're dropping the dose further to 20 gray. And a preliminary results that was published in our national meeting 3 years ago did show that even if you drop it to 20 gray, that should be okay. I know probably what's running in everybody's mind right now, if you can drop it that much, then why do you need it in the first place? And then in the last section of my talk, you will know why is it that you need it. So in summary to this, you could see that we have dropped the dose in follicular lymphoma to 24 gray, in diffuse large B-cell lymphoma, LP Hodgkin, marginal zone lymphoma, mycosis fungoides, myeloma, and mantle cell lymphoma. And the significance of this is that you can still use and benefit from radiation without causing the toxicity that everybody is afraid of. So now I will move to technology, which is what allowed us to drop the dose and be safe with our patients. Technology has helped radiation oncologists big time. As you will see in this video, we scan patients or we do a simulation and we create a 3-dimensional image of their liver, which is in yellow here, of their lung, which is in blue here, and both kidneys. And then if you are treating a mass, which is the tomato, big mass in the abdomen, then you will have the ability to come through multiple windows through a software computer programming that will deliver through a mathematical iteration the dose to where you need to deliver it without affecting the organs at risk. So you can see how in radiation oncology today, because of the development in technology that we have seen, we can deliver things that we could never deliver 20, 30 years ago. Give you examples of how that would work. Let's say that you have this patient with diffuse large B-cell lymphoma with this large mass just sitting at the pole of the kidney and involving the upper pole of the left kidney, as you can see here. The patient did receive dose-adjusted R-epoch, and he came to me actually from Memorial Sloan Kettering. At the end of his therapy, there was a Duvel 4. I personally don't consider Duvel 4 as a bad sign. Quite often, you will see that patients would end up with a Duvel 4, but not necessarily that they have a disease if you wait enough on them. But back then, I treated this person more than 6 years ago. When we had a Duvel 4, patients would undergo a biopsy, and he did undergo a biopsy, and it came back positive, so we needed to treat him. And you can see how you can almost paint the dose where you need to paint it. That purple line is the lowest dose, which is 5 gray if you're giving a 30 or 36 gray. So 5 gray is considered the gold standard to avoid the kidney to go beyond 5 gray, because when the kidney goes to more than 17 gray, it will be completely non-functional. Now, you would wonder, okay, then I can give it up to 17 gray. And that's the major difference between us and solid tumors, like when you're treating pancreatic cancer. We always think that the role of radiation is minimal at best. The benefit from radiation cannot be more than 7-8%, even in progression-free survival in most of the studies that are published. So therefore, the ideal situation is to be able to deliver it, get that, rip that benefit of 7 to 8%, but do not cause any toxicity to the kidneys, even when you think that it is okay. It is okay for pancreatic cancer, it is okay for stomach cancer, but it is not okay for a lymphoma patients that might live for a long time, have many relapses. And eventually, some patient radiation oncologists from around the world, this is why I love this data, they did show that if you are not careful with the kidney and you do not deliver a very low dose when you're treating, about 5 gray, then these patients might come 20, 30 years later with a chronic kidney disease if you're not careful with them while treating a low dose or a low grade lymphoma like multiple lymphoma, for example. So moving forward to how we use technology, I hope that you are able still to hear me and everything is okay. A patient who presented with a bulky mediastinal disease like this, and that is the subject of much debate between medical oncologists and radiation oncologists. This is the heart, this is the mass, and then quite often people would shy away from using radiation, rightfully so, because they would think that we cannot actually safely treat that patient. So this particular patient, unfortunately, and after receiving treatment with ABVD, he presented with a relapse. And as you can see it here. And then eventually went through autologous transplant and received Gem-B-Mel on one of our protocols that Dr. Nieto runs. And it was time for me to give him consolidation radiation therapy. And that's also a subject of much debate, that do you still need it or not? And then when you give it, the point is you have to give it and give it very safely. So we did give it, and we gave a high dose at the time. I wouldn't use that high dose at this point, but we gave treatment. And the point of the treatment was that when you treat, you just chase where the origin of the disease, and you'll be careful that this is the takeoff of your coronary vessels and the left ventricle, and you need to save it. And using the IMRT, which is not everybody who uses IMRT is going to know how to use it, is a tool that the radiation oncologist has to use to its benefit. So it's not like you press a button and you tell the machine to deliver IMRT and you're happy with it. You guide it and you work with it smartly. So it takes a lot of engineering on the part of the radiation oncologist to do it. Obviously, if you don't have time and you are not a specialist, you might run it and just accept it, but that's not what happened. We created a series of techniques to avoid, for example, irradiating the breast in young female. One of them is creating this board that, as simple as it looks, actually, it saved patients with female patients from getting irradiated to their breast. And if you just look at the difference between this CT scan and that one, this is the same cut at the same level, but this is with the board where you do not see the breast. So therefore, when you're treating the patient, you're going to avoid their breast. And this is without the board that we made, which is a simple board that anybody, any radiation facility can come up with it actually. And you could see how we avoided the breast. We also came up with in-house multiple mathematical iteration where you could help to deliver the IMRT while avoiding specifically, as I said, the coronary vessels, the left ventricle, and the lungs. The forest color here is the lowest dose of radiation, which is the 5 gray. When you're giving a dose as high as 40 or 50, it is really an art to be able to avoid the low dose even to go to the lung or the left. Not the high dose. The high dose will be painted only and only where you're treating and the site that you're treating. The low dose will actually be avoided from all the critical organs. And why is it so important for the lungs? If you remember, the patient had prior bleomycin, bisulfan, melphalan, gemcitabine, all lung toxic chemotherapy. So as a radiation oncologist, you need to understand the prior therapy and the toxicity and the added toxicity when you give radiation. And there are times where you have to stand and say, okay, how much benefit I'm giving the patient? Am I able to deliver a state-of-the-art treatment that will avoid the left ventricle because of the adriamycin, the coronary vessels, the lungs, and safely treat the patient? And if we cannot, then we are going to stop and not give it. There is a series of constraints and guidelines that we follow and obey by. One of them is a series that was published by our team from MD Anderson, where we created a nomogram that will guide us as to how much to restrain the dose to the lung, not to end up with pneumonitis, specifically in the case of a prior transplant. We also obeyed pediatric data on the risk of congestive heart failure and coronary artery disease with radiation. And we use the lowest denominator, which is we try to minimize everything to less than 5 gray or less than 7 gray to reach that curve here that is the closest to the normal population versus the curve that when you give a higher dose of radiation, then the risk of cardiac toxicity over time in pediatric patients will go up. And eventually we will criticize every single plan, and we do not let the plan pass unless it does meet all of these constraints and criteria. Proton, I wanted to talk about it just a bit, not because you need to be an expert in proton, but sometimes not to feel so bad that you do not have it. So proton obviously was built based on the success of photon, but also that it is a more precise and less toxic particle. And the idea of proton is that it enters the skin and it goes into a depth where the tumor is, and it just deposits the dose there. So if there is any organ in the pathway here, then it will be safe. So that's the whole idea. It is a density dependent, it transfers the energy, basically a very nice way of depositing the dose without causing any toxicity. But there's always a but. With all the sophistication that we have in proton, we cannot deal with the patient that breathing. And you would think, so what should we do? Well, what we should do is really tell the patient to hold their breath while being treated, because as you can see from this mosaic or rainbow distribution of the dose, it varies quite a lot if you are using proton based on the breathing, and I will show you that right here. If you take the same tumor, but then at the different level of the breathing, the rainbow dose looks completely different. Therefore, it is very important to, when you use proton, to be careful about, one, if the patient is breathing or not. Two, anything that will imitate breathing, like the tumor getting smaller, or there is an inflammation, or the pleural effusion, or the bowels moved and they are not in the same place. So I'm not going to bore you with all of those issues, but I want to tell you that whenever we use proton, we're extremely careful. One of the examples is, if my dose, which is the tomato color here, is touching the coronary vessels, I will replan, because another issue with proton is that at the edge of it, it has a very high dose. Therefore, instead of having this very precise treatment here where the tomato color is the dose and the coronary vessel is sitting next to it, I actually would go for the plan which is below, avoiding those coronary vessels. And every case should be decided case by case. And that's what should happen in those young patients that sometimes we look at them and say, if I had a proton center, I would send this patient to the proton center. If you take a patient where the mass is sitting right there next to the heart, and you say, should I use IMRT, which is photon that I have, or should I use proton? And if you think about it, let's assume that we use proton and that rainbow color distribution is where the radiation is. Well, most of your left heart or left ventricle is in it. All of your coronaries, especially the left one, is in it. So even if I have the ability to use proton in this particular case, probably I wouldn't use it, because if this is a Hodgkin patient or a primary mediastinal patient where I want to give radiation to prevent recurrence, the benefit that I'm causing or I'm giving the patient is not worth it, the side effects that they're going to end up with. We published this proton guideline in Blood just to guide radiation oncologists around the world, especially the one who do not have proton, to not to feel that bad, because there are many issues that needs to be sorted first and foremost before proceeding with proton. So as a summary to my second segment is that we are capable of dose painting and avoiding organs at risk, which is amazing part of benefit that we got from technology. We developed hematological specific constraints that we need to use instead of following the solid tumors one. And we do give differential doses delivery. You can give a higher dose to where to the area that relapsed versus a lower dose to the area that did not relapse. Moving forward to leukemia, my favorite disease to treat and my favorite oncologist to deal with. We have a role in AML, we call it chloroma. Sometimes they do have CNS involvement, and in ALL, which is CNS involvement mostly, or extramedullary sites of mediastinal disease. I am aware that there is a lot of debate in this particular disease, but before we move into it, I want to remind you that a thoughtful radiation oncologist will be still able to give the treatment without causing any toxicity. So what I'm suggesting here is not necessarily to treat every patient, but to consider it and have a thoughtful discussion with the radiation oncologist. So when you think of AML, we quite often are consulted on a chloroma in the brain, especially when they have inversion 16, or when they have a monoblastic type, or have gum or oral disease. They might end up with a CNS disease, especially when they have complex cytogenetics and they relapse multiple times. They might end up with a leukemia cutis also. And if they are going through a transplant, we would usually give them total skin electron beam therapy. Why would we end up with a CNS disease in AML? I have to tell you that almost more than 15 years ago, and when I reviewed all the myeloid leukemias at MD Anderson that were prior to the year of 2006, I did not find that there is a high risk of CNS disease in AML. And now we did that again. and actually there is a higher risk of CNS disease. And the main reason that these patients are living longer. Now we identified that cytogenetics is the driver for the survival of these patients and how we treat them when they're living longer. And as they live longer, and as most of the therapy will address the marrow and the blood, but not the CNS and cross the blood-brain barrier, then you will see more and more CNS disease. So now we look at complex cytogenetics, younger age, white blood cells that high at diagnosis, high LDH or high percentage of peripheral blood, to think that probably that's how they cross the blood-brain barrier. The implication of that, if they are going through transplant, allogeneic transplant, then we attempt to give them, as part of the conditioning regimen, craniospinal irradiation before they go into transplant. So when do we apply it? We apply it if there is a CNS relapse that failed CNS-directed chemotherapy or intrathecal therapy, and there is no prospect of allogeneic transplant, or, as I said, as part of the conditioning prior to transplant with the risk factors that I just mentioned. And the dose that we give is 20 gray. And that's also significant because most of the studies for neurocognitive troubles, not in kids, because the kids are a developing human, therefore giving them radiation is detrimental. But then in a well-developed or a more than 25-year-old adult, when you give them 20 gray, that's considered a lower dose that would not cause the toxicity that we know about. Now, CNS in central nervous system relapse in ALL, that's a completely different story. It's a well-known fact. We know that there are many risk factors to it. It does exist sometimes at presentation, and specifically when these patients now are living longer, as you can see here, and surviving many systemic therapy, and therefore they come with a CNS relapse. So I'm gonna go through two issues here when it comes to the CNS relapse and how we address them with radiation. This is our experience with giving craniospinal irradiation, and there is no doubt that patients who were treated with craniospinal irradiation, or at least the whole brain, not base of skull, those are the ones who did the best. But we also were aware that maybe it's a surrogate for not the fact that we gave them radiation, but the fact that they were able to make it and go through transplant. And for that reason, again, we're very thoughtful. We do discuss it case by case. It's not a blanket recommendation where you say everybody is going to get CSI if they're going through allogeneic transplant, but we look at multiple issues. Mixed lineage leukemia, very high blast, multiple CNS relapse before, and then we recommend it. We published a guideline that your radiation oncologist would be happy to see about when we're dealing with CNS recurrence in ALL, when is it that we need to apply radiation? And as you can see here, it's well known to all of you, I'm talking to the right audience here, that mixed lineage, early precursor T cell, complex cytogenetics, Philadelphia-like, MRD positivity, all of these are risk factors. When you're going into transplant, you want to make sure that you're not going to end up transplanting this patient and they would come back with a CNS disease while the marrow and the blood are in remission. This is how we give the craniospinal irradiation. I'm not going to bore you with this, but I want to show you what we discovered along the way when we're treating these cases, which is, let's say that these are the risk factors. You have a patient coming into the clinic, the patient received most therapy, and when you think that you're dealing with a CNS leukemia, please think again, because I'm going to present to you this particular case of a 27-year-old who presented with an ascending paralysis. He had 2 years history of ALL. He was a T cell type. He had high white blood cell count at presentation. He did achieve a CR with hyper-CVAD regimen. And it was a short-lived CR. Then he underwent allogeneic transplant. 4 months later, he presented with these neurological symptoms to the ER. So you can imagine that as a radiation oncologist, you're going there after all what I told you, that's the first thing that comes into your mind, that it must be that this patient has CNS leukemia because he checked all the boxes that we talked about. So they did the CSF and there was 25 white blood cells and a high protein. They did an MRI, there was no leptomeningeal disease or spinal disease. And the pathologist came back later on and said that I do not see any blast in the CSF. As we're speaking, the patient developed urinary disturbances and the leukemia team consulted us and we were going to give radiation as soon as possible, but we did not recommend radiation because at that time we suspected toxicity due to previous CNS directed therapy. And what's now a common practice back then was really a learning experience. We counted the total number of intrathecal that the patient went through and it was 35 total over 17 months. Then we ordered an MRI and one of our radiologists, Dr. Linda Chi, who helped us navigate through the MRI, noticed that there is a T2 signal intensity in the dorsal column that you can see it right there. And up and further, look in the literature, we found out that actually in pediatrics, these cases have been published where patients with TL-ALL, they present with the same symptoms as our patient, and they do have a myelopathy in their dorsal column when you do an MRI and a T2 weighted image there. So then we went ahead and collected all of our cases that we thought we never gave them radiation, but they ended up with this image. And we published it with our leukemia colleagues. And we found out that there are 13 patients that developed the same symptoms and had the same dorsal hyperintensity on T2 MRI. And now we know that probably this is myelopathy from intrathecal methotrexate. And I will give you another hint after that, but let's concentrate on what labs might be disturbed in this case. They might have a decreased folate, decreased vitamin B12, elevated homocysteine, or methylmalonic acid. So they have a decrease of what it takes to metabolize the methotrexate and an increase of the products when you do not metabolize it. And what I wanted to say is we also discovered that when we give the high dose methotrexate as part of the hyper-CVAD, often the same day, we might be giving the intrathecal methotrexate to these patients, which means there is a peak of the dose of methotrexate in the CNS. So since that paper, it was decided by our leukemia colleagues, one, not to give the high dose methotrexate at the same time frame of 48 to 72 hours with the intrathecal methotrexate, and two, to be absolutely careful about these cases when they present to us and to always check if we are dealing with the toxicity. And three, to limit the number of intrathecal methotrexate to 25. It's an arbitrary number because in our papers, we found out that anytime we pass a total of 17, then the risk was there. Unfortunately, one of the cases that we saw, we gave radiation when the patient having the neurological symptoms from the myelopathy. And what we discovered is that if you give radiation and the patient is having myelopathy, you actually might cause further devastation of the dorsal column. And as you can see in the autopsy, we performed an autopsy on this particular patient, and there was a prominent necrosis in the dorsal column, confirming that it is an axonal problem and it is a problem in the posterior or in the dorsal column myelopathy. So as a recommendation right now, whenever we suspect a heavily pretreated patient, we look at the number of intrathecal, we check for ascending sensory and motor weakness, and we make sure that not to get fooled that this is a Guillain-Barré, because that's the next most common diagnosis that we get. If you have a negative CSF, that should raise your suspicion. And if you have a negative MRI, that should raise your suspicion. It is important to go look for myelin basic protein in the CSF to see if the myelin sheath marker is increased. and to look for low folate or vitamin B12, and for the elevated products of not being able to metabolize it. One word about lymphoblastic lymphoma. Again, this is very debatable, but it has been our practice at MD Anderson that when we get lymphoblastic lymphoma, we do give radiation to the area of the mediastinum. Having said that, if your radiation oncologist is not able to give it with the minimum toxicity possible, which means completely avoiding the left ventricle and the coronary vessel, only chasing where the thymus is, not chasing everything that the patient had, then they can give it. Otherwise, you should leave them alone. Testicular, we treat it if it is positive. We do not give it as a prophylaxis, but I know that many of my colleagues in the US, they do that. The last thing that I'm going to talk about in leukemia is the total marrow irradiation, which is going to be the new TBI. And the idea is that you only follow the marrow and you try to avoid the organs outside of the marrow. The benefit is that you concentrate the dose to the bone marrow, you avoid the organs at risk. And there is one of the studies that I'm doing with my colleagues in transplant is to do a differential dose of myeloablation in AML. As you probably know more than me, in AML, we rarely use myeloablative regimens. But then in this particular case, our colleagues are interested in doing two things. One, ablate the marrow, so they would prevent the AML patients from relapsing, but at the same time, give a low dose to other organs like lymph nodes to be able to prime the immune system. So as if you're doing the two kinds of TBI, the non-myeloablative and the myeloablative, one to prevent the relapse in the marrow and the other one to prime the immune system. And speaking of the priming the immune system, that brings me to the last section, which is how can radiation prime the immune system prior to immunotherapy and CAR T-cell therapy? And as you know more than anybody else, this is we know that tumor survives by evading the immune system. That creates multiple pathways for us as radiation oncologists to work on. And the way radiation works in a nutshell is that it does reprogram the tumor microenvironment. That's why going back to the first section that I talked about, how does a 4-gray work and why do we need it in the first place? Because radiation can reprogram the microenvironment and then will cause an immunogenic cell death. And it is for that reason a 4-gray in a multiple lymphoma or in a mantle cell lymphoma can work. It also can create a struggle. We cannot at this point claim that we know how radiation works or how we can communicate with the immune system. And it is not a problem obviously for us, it is a problem for everybody who's applying immunotherapy. Supposedly radiation would hit the tumor and then it will create antigens that will go into the lymph nodes. The naive CD8 plus T cells would become activated and there will be a cascade of immune response that will create all of those wonderful pathways for us as radiation oncologists to work on. And that's what created what we call the radiotherapy and immunogenic cell death, where you could eventually not only work on the T cells, but also increase the T cell surface translocation, which is the eat me, do not eat me signal to our benefit. I'm going to give you a few cases from the clinic just to show you how we prime the immune system. So this is an example that I saw in the clinic of a diffuse large B-cell lymphoma, as you can see in the abdomen and all of those PET scan axial images. I started the patient on treatment with radiation, and my medical oncologist, without me knowing, did a PET scan 7 days later. And to my surprise, that's how the PET scan looked like. You see, the tumor that I'm treating, it was there, now it's gone. But then you have all of those lymph nodes that are angry. And when we did the biopsy, it was just a lymphoproliferative proliferation. Therefore, we primed the immune system. Now, priming the immune system, as I said, is not a simple matter. Sometimes you prime, you cause T cell exhaustion, and then you have to come back after. This is a very important Nature paper from our colleague in UPenn in melanoma, where they gave the radiation and then the anti-CLA4, and then eventually hit resistance. So then they added the anti-PD-L1, and that's how they got to an excellent response in melanoma patients. The take-home message from this slide is that it is true that we are treating with a complex picture when it comes to the immune system. Therefore, it is very important to recognize that, and it's not going to be a simple fix where you give radiation or you give the immunotherapy. The timing matters and the sequence matters a lot. This is a typical of what we're seeing these days in the clinic. A patient that presents with diffuse large B-cell lymphoma had a complete remission on dose-adjusted R-epoch, relapsed again, had a response to R-GMOX, and then the patient is about to receive CAR T-cell therapy, but he still has all of this disease, including the one next to the heart. He comes to our clinic. This is the field of radiation we treated. We did not go after the one next to the heart because we wanted to avoid toxicity. Before going to CAR T, and as part of doing a restaging workup, the patient was restaged with a PET scan. And as you can see, the disease that was treated by radiation is completely gone, but then you have all of those activities around. That's how you prime the immune system. Then he proceeded to CAR T and he had a durable response. So that led to understanding from many of the trials that were done in CAR T cell therapy where radiation was used or allowed. It wasn't only that we are trying to bridge the patient in a sense that just get the tumor, but actually we were priming the immune system. And now we know that radiation worked in these trials because of the immunogenic cell death. And the dose was very important too, because you cannot give a high dose, and you shouldn't give a high dose, because as you go higher in the dose of radiation, the benefit that you got for priming immune system, you might lose it, because that would offset, the highest dose would offset the increase and produce an increase in the Treg representation, which is something that you might not need. Therefore, we decided that, and based on many of the studies that were published in solid tumors, some of them, that a lower dose of radiation, as opposed to 40-50 gray that we use in very aggressive lymphoma and refractory lymphoma, is the dose that we're going to be giving. And many of our colleagues, including ourselves, MD Anderson, Memorial Sloan Kettering, and Moffitt, they published multiple papers. But then what I want to attract your attention to is that the lower dose of radiation, as opposed, as I said, to 40-50 gray, now the 20 gray is the one we are using in radiation. Timing. So when to give it? We do not want to give it before the conditioning to CAR T, but we definitely want to give it in a way that CAR T infusion would be within 14 days. This is an animal study that was done. And what it showed is radiation does disturb the immune system, and it takes around 14 days for the immune system to regain back its normacy. So based on that work, we decided that if we want to give radiation prior to CAR T as priming the immune system, we're going to do it within 2 weeks from the infusion of the CAR T. The last part that I'm going to talk about is how about after CAR T cell therapy. So you have this heavily pretreated diffuse large B-cell lymphoma. On day 13 of the CAR T cell therapy, they came with pain and neurological symptoms from a lesion at the level of T12, as you can see it right there. It was day 13 from the CAR T cell. I was very worried about treating this patient. And the reason I was treated, because as you know more than anybody else, that the CAR T cell peak would be around this date. So eventually I decided to treat with this very small field of radiation just to relieve the symptom of that patient. Then eventually the patient went into remission. And we were puzzled. Could it be that we actually reprimed or re-expanded the CAR T cells? And the answer came from our colleagues in Memorial Sloan Kettering in myeloma, where they had this patient that they gave BECMA. And as you can see that the radiation was giving at a time where the cells were de-expansion, and then as soon as they gave the radiation, then the cells re-expanded again. And they ended up by concluding that the TCR clonality analysis demonstrating that there is an expansion of the novel TCR clones. And that's actually helped us to start a trial, a prospective trial at MD Anderson, where we take all patients with myeloma that failed BECMA and give them radiation and see if we can re-expand their treatment. I will stop here and say that our take-home messages are that we showed that we can effectively treat while reducing the RT dose. We use technology to our benefit, and we're very thoughtful about it. We gained a role in leukemia, and we definitely, the most exciting part, we gain a role in relapsed refractory disease, and we can prime the immune system. Thank you so much for your attention, and I'm happy to take any questions.
Thank you so much, Dr. Dabaja, for that wonderful update. Fantastic research, fantastic work you shared with us. It's amazing what you have contributed to this field and updated us in India. My friend, Dr. Nagaraj is here. I'll request him, he's a radiotherapist with us. I'll request him to ask you whatever he wants to ask.
Yeah, I have a couple of questions and a wonderful talk that we heard. I was wondering as to whether you would look at the texture analysis in lieu of PET scan or any other imaging to decide the total dose, especially clinically evident disease.
Hello,
can you hear me?
Yes, I can hear you. I'm thinking.
Yeah.
So,
I have two questions. I have two questions. I've probably heard my first question.
Let her answer the first one. Yeah.
Okay, let me answer your first one. PET scan is progressing and developing. Let me stop sharing, actually. No, I'll share in case I need to show you something. PET scan, as we know it 10 years ago, is completely different than the knowledge that we know from it right now. And I know where your question stems from. It stems from the fact that as we knew PET scan, we always said 1, 2 is complete remission, 3, 4, 5 is not. And then we changed our mind and we said 1, 2, 3 is complete remission, 4, 5 is not. And now we're changing our mind again and saying 1, 2, 3 in majority of 4 is complete remission and 5 is not. So as radiation oncologists and medical oncologists go through this roller coaster, they at some point decided, okay, well, if 3 is not, then I need to give a differential dose. And if 4 is not, then I needed to give a differential dose. Because they were still thinking of the old times when we used to say unconfirmed CR or a PR. And most of the PR of 40 years ago on CT scan, probably they were CR. It's just that you have a residual sclerosis, which is probable in half of the lymphoma that we treat, from Hodgkin to primary mediastinal lymphoma to lymphoblastic lymphoma. All of these are going to leave you some of a CT residual that will leave you scratching your head, is it disease or not? Then you came with PET scan, and the PET scan at the beginning, it's a learning curve. So then you go and say, what am I going to do with Duvel 2? What am I going to do with Duvel 4? The short answer to what I'm saying is no, because really PET scan at the end of the day is going to become a no or yes, positive or negative. This whole thing about the Duvel is only to make us think that if there is a small activity like the one I showed you in one of the slides with a small residual on the CT, that activity could be nothing, post-inflammation, post-chemotherapy, you just leave it alone. Or if you repeat the PET scan, which is something I do quite often right now, I get a patient with primary mediastinal lymphoma with dose-adjusted R-epoch, I leave them alone. 6 weeks later, I come back, I repeat the PET scan, and quite often it's gonna go away. So there is no point to get so excited as a radiation oncologist and say, I'm gonna give a differential dose, because the future is that probably will never give anything past 30 gray.
Thank you. That's lovely. Would you consider lattice for a refractory large lymphoma? Lattice radiation with lattice technique? I mean,
I am not aware of that. No.
Okay. And thank you so much. Maybe we can
No
move on.
problem.
Thank you.
Thank you, Dr. Nagaraj. Dr. Verma, your question.
Thank you, ma'am, for the nice talk. So I just wanted to know in orbital lymphomas, what precautions we should take and what are the complications of radiation while giving orbital lymphoma? And you mentioned about the dose of 4 gray for marginal zone lymphoma. So if it is DLBCL or follicular orbital lymphoma, how it is different? Radiation is different for those. Thank you.
Excellent question. So if you are giving 4 gray for marginal zone lymphoma, follicular lymphoma, mantle cell lymphoma of the orbit, the side effects are going to be extremely minimal because you have to think what are the organs that you are radiating and they're going to cause you side effects. Is the lacrimal gland, right? The lacrimal gland tolerance is more than 20 gray or less than 20 gray. Therefore, if you're giving 4 gray, then you're safe. And therefore, that dose is safe. How did we learn about it? Because we had many diabetic patients that we treated and many patients with either scleroderma or Sjogren disease or a problem to start with a dry eye. So then we said, okay, let's do a staged approach, especially in multiple lymphoma. And we first treat with 4 gray. And if we don't have a response, then we would increase the dose. Now, I have to tell you, before I answer the diffuse large B-cell lymphoma, I have to tell you something that is absolutely my personal opinion. I do not believe that multiple lymphoma is a cancer. And the proof to it is that you can leave those patients for 20 years and they will never die from it. And for God's sake, how could a cancer be treated with antibiotics? So, but for a carpenter, everything is a hammer, right? As soon as a patient with multiple lymphoma would show up to the clinic of the oncologist, they cannot help it. They have to treat them aggressively because it has the word cancer. But then the reality is that it doesn't kill anybody. And in my opinion, again, my personal opinion, it does not transform. And if you treat it with antibiotics or sometimes leave it alone, it will go away. Therefore, 4 gray is more than enough. Now, for diffuse large B-cell lymphoma, that is really a big issue because treating the intraorbital diffuse large B-cell lymphoma or primary orbital lymphoma is a deceiving topic because you give 30 gray, you give 36 gray, but those patients, they're going to come back with a disease either in the orbit or in the brain. At this point, we give them 30 to 36 gray. We give them high dose methotrexate. The toxicity from the treatment is dismal because they're going to end up with a dry eye, with trouble with their cornea. So yes, it is completely different, but us and our colleagues in medical oncology, they're having issue with this disease and controlling it to the future.
Thank you.
So, ma'am, lens sealed is must for all these patients.
Say it again.
To prevent the lens from, radiation toxicity.
In the multiple lymphoma, there is no point of preventing the lens from toxicity because the worst thing that is going to happen that you're going to develop cataract. And instead of developing cataract as a patient at the age of 55, you might develop it at 50. So it is not worth it to go ahead and put the block in front of the lens. Bottom line that we never block the lens if we're giving 4 gray or if we're giving higher dose because then you could block the disease, which doesn't make sense. But I am aware in many institutions, they still do that.
Thank you, ma'am.
But we don't.
Thank you.
There's one question from the audience. Role of radiotherapist in primary CNS lymphoma.
All right. I really think that we have a role, which is 2 kinds. The first one is if you have a patient that achieved the complete remission and they're ready to be discharged to the wonderful life they have, and you give them 23.4 gray, which is, again, I think I want the audience to leave today with the following notion. Anytime we had toxicity from radiation is based on the old data where we used to give higher dose total and higher dose daily, which makes perfect sense. And to put it in a context that medical oncologists will understand is that if you give adriamycin IV push versus drip over 48 hours, it's the same dose, but then the toxicity is wildly different. Or if you give the dose-adjusted REPOC, where you're giving the etoposide, putting the patient in the hospital for 4 days and giving it as a continuous infusion versus when you give it over 4 hours. So it's the same story with us. Therefore, anytime you are giving radiation, the daily dose matters and the total dose does matter. Exactly how it matters when you say, I gave 250 milligram per meter square total of adriamycin versus now I am at 500 and the risk of congestive heart failure is gonna go like this after another 1 milligram of adriamycin. At 23.4 gray, and based on the Memorial Sloan Kettering data looking at the neurocognitive function, it is safe. So that's that. Now, if I have a patient that failed all treatment and still having disease in the CNS, then I use the following approach. I follow the disease where there is a recurrence with a higher dose using IMRT. And then I spray a low dose in the rest of the brain, because we are all aware that the whole CNS is at risk. But I personally think that there are different ways on how to look at it. I'm not going to go into this because I was going to say that we published a paper on secondary CNS and on primary CNS, and we did show that there is a difference of the dose distribution in between these two, in a sense that secondary CNS might be treated and cured actually with radiation, while primary CNS lymphoma, you have to give the low dose to the whole brain. So to make the long story short is, if you have a relapsed refractory case and you cannot use anything else and you want to use radiation without causing the patient neurotoxicity, then you only chase the areas where you see the relapse and you give a very low dose to the rest of the brain.
Thank you. Dr. Jeevan, your question.
Yeah, thank you for the wonderful talk. So my question is, in TBI-based conditioning chemotherapy in patient with CNS relapse acute lymphoblastic leukemia, so any role of giving CNS boost along with TBI?
Yes. So anytime that I want to consider, anytime you have a CNS relapse in an ALL, then before getting on board, there are a few questions that I need to be answered, which is the following. Is this patient a candidate for transplant? Is he going to be treated definitively? And if that's the case, then the next question that would follow always, is he going to go through a myeloablative regimen with the TBI or not? If the patient is going through transplant, then I would leave the leukemia team to manage him with intrathecal high dose, whatever they want to give, until the time that he's going through transplant. And then at that time, I will deliver the craniospinal irradiation. Then I would ask the transplant team what kind of a TBI they are using, or if they're using a TBI or not, or they're using thiotepa. If they're using a TBI, then what I would do is divide the dose. If you give TBI, quite often it's going to be equivalent of 12 gray. Because I was going to use 24 gray for the craniospinal, now I use half of it. So then what I do is I use half of the dose, the craniospinal, which is only 12 gray for 6 days. Then I move with the TBI and then the transplant. That way I would have got both of my wishes, control the CNS and get the myeloablative regimen. Is this your question?
Yeah, thank you. So my question was that if we give full dose TBI, myeloablative TBI, so we can combine it with CNS boost.
Yes.
Yeah. One more query is that there is some minimum gap between high dose methotrexate and the TBI?
For the CNS disease, for the craniospinal, you mean?
Yeah. If we are planning for a TBI-based myeloablative transplant, what should be the minimum gap between high dose methotrexate and the time of TBI?
Okay. I really think that so when you give the high dose methotrexate, you wait on them until they clear from the body, you wait for 72 hours to make sure that they are out. And if you give it a week after, that should be enough, because there are two things you're looking at. You're looking at the pharmacological part, and you're looking at the devastating neurotoxicity. The pharmacological part is in your hand, and you know that waiting for a week is the safest in case the patient did not clear it. The neurological part, really, there's nothing you can do. We always want to do the following sequence, which is give radiation at high dose methotrexate, none before. So going back to your first question, another question that I ask my leukemia folks is, if you're dealing with a CNS disease, finish all the high dose methotrexate that you're thinking about before I would come and interfere. So a quick answer to your question is that I would wait a week.
Thank you.
Thank you. A question from the audience.
I'm sorry, but also you have to remember, with high dose methotrexate, you're going to cause pancytopenia. So the patient probably is not going to recover until another 2 weeks. So there is no way that you're going to be going from the high dose methotrexate immediately into the transplant without a gap of a good 2 to 3 weeks. Add to this, anytime you're going to give high dose methotrexate, the pancytopenia would become deeper, and the recovery would become later and later. So it's the patient who's going to give you the gap, not you. Sorry, go ahead.
Thank you. There's a question, pediatric T-cell acute lymphoblastic leukemia. Is there a role of prophylactic cranial radiotherapy?
I cannot claim that I'm a pediatric expert, and I do not treat pediatrics. So I would like to refrain from answering that if possible.
Fair enough. Dr. Chand, this is all over. Nobody does it now. Okay. Next question is from Dr. Mishra. If you have a bulky mediastinal classical Hodgkin lymphoma, and after treatment, both interim PET scan and end of treatment PET scan are negative, should we still give a radiotherapy to that bulky mediastinal mass to start with?
Okay, I can see the questions right now, so I'm going to read. For a patient with bulky mediastinal classical Hodgkin, you consider consolidation even if the interim and PET scan show the CR. Okay, if I was 15 years younger, I would have told you yes. But now I'm going to say not necessarily. I'm not completely keen right now on treating bulky mediastinal disease in Hodgkin's lymphoma unless I can really give them an excellent radiation plan. And that's what I tell my colleagues around the nation in the United States. If your radiation oncologist is very in tune with technology and willing to consider showing us the plan and going through it, then yes, if you're able to completely avoid the breast and the coronary vessels and the left ventricle, then go for that 6-7% benefit that you're looking for. If not, then no. So it is honestly a case by case. Second, role of isolated splenic radiation versus single agent rituximab in splenic marginal zone lymphoma with no disease in the marrow. I love this question. So I have a patient that we go back and forth between me and the medical oncologist, and believe it or not, the medical oncologist wants to give him radiation and I want to keep him on the rituximab. The reason being, I think that if the patient is asymptomatic and doing well with the rituximab, then leave them on it and not necessarily give them the radiation. Plus, marginal zone lymphoma of the spleen, they do very, very well. I mean, you can give them 4-gray if you want, but both of them are okay. Having said that, and during the pandemic, and because rituximab is a B-cell killer, and since many of the studies now coming that during the pandemic and because of the COVID, they might not be able to mount immunity to the vaccine or mount immunity if they get the infection, then I do understand if you don't want to go with the rituximab, but do want to go with the radiation. I hope I answered that well. Please enlighten us about differences between total body and total marrow irradiation and total lymphoid irradiation, which has best results in bone marrow transplantation. Yes. Total body irradiation is your old method of, I can't see anything, I'm just gonna blast the whole body without seeing. Total marrow irradiation benefits from the fact that now we have computers and CT scans, and we can see every single little thing in the body in a 3D format. And we would say, I could deliver the dose differentially in the marrow or the spleen and avoid the liver, the lung, the bowels. Now, having said that, don't let any radiation oncologist fool you that when I say that I would deliver the dose to the marrow, but not to the liver, that is going to be a black and white. There is nothing black and white. If you remember your high school physics, you will remember that energy doesn't disappear. It just transforms from one thing to another. Therefore, when you say that I'm moving the dose from one place to another, you are moving it, but not completely. The dose has to go somewhere, basically. So you either use a rudimentary way of how we use TBI for the past 50 years, which is blast the whole thing with an open field, or you say, I'm going to be more sophisticated right now. Just go after the bone marrow and let a bit of a dose go to the rest of the body. Now, having said that, that's why we came up with the protocol that I mentioned with our transplant physicians, because total marrow irradiation is used in many places in major academic centers that do transplant in the United States. But I had issues with it because when I'm treating ALL, I do not want to avoid the brain. I want to give some of the dose of the TBI to the brain. I want to give it to the spine. I want to give it to the mediastinum. I want to give it to the bone. I want to give it to the kidney, because ALL is notorious for coming back and relapsing in these areas. So if you use total marrow irradiation, where you're only chasing the bone marrow, you're going to avoid areas of possible recurrences in ALL. Therefore, in my opinion, it became a perfect substitute for AML, where you do not see that many recurrences in the kidneys or in the lymph nodes. And that way you would have this differential dose where you deliver 12 gray to the marrow and maybe 4 gray, because you have to deliver those 4 gray. It's not that I want to deliver it. It's an excess dose that has to go somewhere. You deliver it to the spleen, the liver, the lymph nodes, and it will prime the immune system. Total lymphoid irradiation, yes, it is used by our colleagues in Memorial Sloan Kettering prior to transplant. They swear by it. And the difference is that you're only chasing the lymph nodes in the neck, in the axilla, in the mediastinum, in the abdomen, based on the fact that in the old days, lymphoma existed in the lymph nodes, and therefore you're trying to chase it and deliver it there. It actually only makes sense for Hodgkin's lymphoma rather than anything else.
Thank you. Any other question from the faculty here? Okay, if none, then...
Yes, sir, I just wanted to...
Yeah, please.
Yeah. So, Dr. Dabaja, solitary plasmacytoma, osseous versus extra osseous. What dose you would recommend now? Because we know, classically we counsel for 40 to 45 grays.
So this is one of the other subsites that we lower the dose. In the past, we even at MD Anderson, when I was a resident, we published 55 gray. Then some of our colleagues from Princess Margaret, they published that for osseous one, they dropped the dose to 35 gray in 14 fractions. So you can see they dropped by 20 gray. And what I do right now is I say, if I have an osseous one, I would give it around 40 gray, max 45 gray, but I'm trying to lower the dose. If I have a soft tissue one, I would definitely do 35 gray. And that's what I do in my clinic right now. So for the osseous one, I drop the dose and I base it on a publication that we did probably 9 years ago, looking at the variation of the dose and that it did not affect the outcome. And then for the soft tissue, I depend on the Princess Margaret data showing that 35 gray is enough, and I give it in 14 fractions for soft tissue solitary plasmacytoma.
Thank you.
Those are good questions.
Thank you.
Thank you, Dr. Dabaja, for sparing your valuable time. Once again, being with us. This has been the 4th or the 5th time, every time so much of learning, and we are grateful.
Thank you so much. I'm really, really honored to be with you. As I said, I always have a smile on my face when you guys invite me. It's really a pleasure and an honor. I hope to be with you one day in person.
Sure, definitely. And have a wonderful day ahead. Bye-bye.
You too. Thank you.
Bye. Good night to all the Indian colleagues.
Thank you.
Thank you.
Good night.